watching from Los Angeles, California.
Hello, we're watching from Melbourne in Australia. Hannah, are you going to say hello?
Hi.
Hello.
Hi, we're the Sachs family, watching from Brookville, Maryland.
Hi, this is Lainey Etkin. I'm looking forward to my 8th FD Day, and I will be watching from Bridgehampton, New York.
Hi, we are the Adanowski family, watching from Montreal, Quebec, Canada.
Hi, we're the Meckler family.
Hi, we're the Olsen family.
And I'm Jonah Sachs, Justin's brother.
And we'll be watching from Boston, Massachusetts.
Hello from the Clausens, from Woodstock, New York, Mara's Art Residency.
Hi, this is Marcia Cohen and Franny Cohen, watching FD Day from our house in Charlotte, North Carolina.
Thank you. Hi, it's Mimi, and I'm watching from Montreal.
The Brenners are watching from New City, New York.
Greetings from sunny Florida in Boca Raton. I wish I was there with all of you for FD Day, and thank you for all of your work, especially everything you've done for my amazing nephew, Jack Attack. Love, Aunt Mimi.
We are watching from Brussels, Belgium.
Hi, everyone. For those who don't know me, my name is Faye Ginsburg. In addition to my work as a professor of anthropology at New York University, I'm honored to be in my 13th year as president of the FD, or Familial Dysautonomia Foundation, on this 40th FD Day, and to have learned about FD from my daughter, Samantha Myers. It's a pleasure to welcome you on behalf of the foundation. 2026 will be our 75th year, a milestone we'll be marking with in-person and virtual events, so please watch our website for information. We are a small but mighty organization. It is remarkable to be launching an era of genetic therapy, given our very modest beginnings in 1951, when a handful of FD families, the first ever to be diagnosed, got organized to share information, raise money, and offer moral support to one another. More or less what we're continuing to do. Now, going virtual enables us to have so many more of you participating today from all over the planet. We especially welcome members of the FD community from Israel and extend our concern for the difficulties and terrible losses that people have been experiencing since October 7th, 2023, and we have tried to lend our support. In particular, I want to thank our very skilled Hebrew interpreters who are providing live simultaneous translation of today's events. To access this translation, please click on the globe icon at the bottom of the Zoom screen and select Hebrew. To enable captions, select the Show Captions icon and then indicate your language preference. Whoops. The foundation has achieved a number of significant milestones in our 7 decades. In 1969, the Dysautonomia Center was launched at NYU Langone Medical Center with the foundation's support. Through greatly improved medical care under the guidance of Dr. Axelrod, followed by Dr. Kaufman, as well as Dr. Gonzalez Duarte, who joined our team in 2021, FD was transformed from a fatal childhood disease to a manageable condition. Over 3 decades, the foundation has raised and invested millions of dollars in research with significant results, including the 2001 identification of the mutation that causes FD. Since then, genetic testing has resulted in the birth of healthy babies worldwide to families where both parents carry the FD mutation. This genetic knowledge has also been foundational to the cutting-edge treatments that you'll be hearing about today. We are especially excited that we have 3 promising genetic therapies moving forward. To learn more, please, in addition to the presentations today, I urge you to go to the Foundation's website to download the comprehensive 2024-25 year in review of new FD research and treatments, a publication of the Dysautonomia Treatment Center. We've been privileged to attract financial support from both private and public sources. As I'm sure you're all aware, we face a very challenging and unexpected situation under the Trump administration, which has been cutting government funding of many extraordinary medical and scientific research initiatives, as you'll hear about today in Dr. Sauenhaus' talk. It is up to all of us living in the US to pressure our congressional representatives and senators to reverse these senseless decisions that harm not only our community, but so many others. The Foundation will post information about how to stand up for public funding of research that will save and improve FD lives and those of so many more. One thing is clear, FD advocates know how to make our voices heard and know how to persist. Before turning things over to our next speaker, some thank yous are in order. We are so fortunate to have the brilliant leadership at the NYU Dysautonomia Center, Dr. Horatio Kaufman, Director of the Center, and Felicia Axelrod, Professor of Dysautonomia Research, and Dr. Alejandra Gonzalez Duarte, Co-Director of the Center, and Carl Seaman, Professor of Dysautonomia Treatment and Research. Thanks as well to Dr. Patricio Merlar Bernetti, part of our medical team, who will be moderating the Q&A session, and to our extraordinary nurse practitioners, Kaya Dalamo and Adriana Barnett. We are grateful to Program Coordinator Leanne Lugg and to the rest of the team at the Treatment Center. I also want to express gratitude to our Scientific Advisory Board, especially the dynamic leadership of Dr. Frances Lefcourt, award-winning research professor of cell biology and neuroscience, Emerita. She co-chairs this advisory board with Adam Sachs, a biopharmaceutical expert and FD parent, who has launched Tikkun Therapeutics, a public benefit corporation focused solely on the development of therapeutic drugs for FD. Let me also convey my deep appreciation to our foundation's devoted and resourceful board of directors who do so much to ensure a consistent level of support for the Dysautonomia Center and the FD community. Kudos to them and the many people they have motivated to contribute to our cause, raising not only money, but spirits and awareness as well. In particular, I want to acknowledge an extraordinary gift of $500,000 distributed over 5 years from the Claire and Philip Wexler Research Fund, named in memory of board member Paul Wexler's parents. The fund has supported many of the translational research initiatives being discussed today, bringing work from the laboratory to our community. Finally, I am so profoundly appreciative of our extremely capable and dedicated executive director, Lainey Etkin, now in her 8th year, and the excellent foundation team, in particular, Albalena Prabhukaj, our accomplished fundraising and comms manager, who's been doing such a great job with social media, and Julia Weiner, our outstanding development operations associate. I want to thank them for their exceptional work throughout the year and especially for today's event. So once again, it's a pleasure to welcome you today. And now let me turn things over to Executive Director Lainey Etkin.
Good morning. I'm delighted to join Faye in welcoming everyone to FD Day 2025. This is the FD Foundation's 40th year of hosting FD Day and our 6th year offering this annual conference virtually. Once again, this year, we are presenting FD Day on the Zoom Events platform. These days, most of us are familiar with Zoom, but if any time you experience technical difficulties, please call the Foundation office at 212-279-1066 or send an email to info@famdis.org. The Foundation team is standing by to assist you. Please note, the Zoom platform includes a chat function where you can post a message to everyone or to specific people who are also attending the event. We encourage you to chat throughout the program. Tell us where you're watching from, send greetings to your friends who are also online, post words of encouragement to our speakers. We want to hear from you. There's also a Q&A box where you can post questions at any time throughout the day. During the live Q&A session later in the program, your questions will be addressed to the panel of FD clinicians, researchers, and others. We will try to get to as many questions as time allows. You know, I've often seen FD Day referred to as the disease no one has heard of. So today on FD Day, let's make some noise. Let's all boost FD awareness by posting on our favorite social media channels and using the hashtag FDDay2025. Now, I'd like to take a moment to acknowledge and thank our very generous FD Day sponsors. Patrons, Faye Ginsburg and Fred Myers, in memory of Samantha Myers. Our partners, Debbie Scheinberg, in memory of Samantha Myers, Tova Weiser, in memory of Howard Weiser, Dr. Felicia Axelrod, Chaya and David Katzenstein, Devora and Stuart Landau, the Sonnenschein family, Town Total Compounding, Mike and Wendy Zucker, and our friend Todd Wolf. Support from these donors helps offset the cost of producing FD Day, enabling the foundation to dedicate more resources to all of the incredible initiatives you will hear about today, including medical care, scientific research, education, and outreach, as well as community building programs and initiatives. It's not too late to join. If you'd like to support FD Day or contribute to the FD Foundation, please scan the QR code in the chat box or visit the FD event page on the Foundation website, famdis.org, at any time during or after FD Day. As Faye mentioned earlier, one of the key benefits of keeping FD Day virtual is that we can truly embrace the international scope of our FD community and include families, clinicians, researchers, and friends from all over the world. The FD Foundation here in New York is proud to partner with our international chapters, and today we are pleased to share a message from the Israeli FD organization, but you already heard that, so we're going to skip forward. The FD Foundation is proud to partner with our Israeli FD community in many different ways. We realize that the situation remains difficult for our friends and colleagues in Israel, and we want you to know that we continue to keep all of you in our thoughts and in our hearts every day. Now let's take a quick overview of today's agenda. We'll kick off the program with a fascinating session presented by Drs. Horatio Kaufman and Alejandra Gonzalez Duarte and their clinical team from the Dysautonomia Center at NYU, as well as several guest speakers. The segment after that will feature presentations from some of our esteemed scientists providing the latest updates on FD research. Next, we have reserved about 30 minutes for a live Q&A with the clinicians and scientists. Some of you sent questions in advance. If questions arise during the program, you may add them to the Q&A box. We'll be monitoring the box throughout the day and will share questions with the panelists as time allows. Following the Q&A, we will share a brief update from our amazing counseling team. After that, we will meet this year's distinguished award winners, view a presentation of the FD Day art competition, The World Through My Eyes, and present the 2025 FD Champion Award. Immediately following the conclusion of the FD Day program, we will invite people with FD to join our ever-popular after party with facilitator Michelle Schwab. For this year's after party, the social committee has planned a game triathlon. You won't want to miss it.
Hello everyone. My name is Yael Kurtz. I am the younger sister of Tal Kurtz, who has familial dysautonomia. On behalf of the Israeli Familial Dysautonomia Foundation, we are delighted to celebrate this significant 40 years milestone with you. I am moved to join you on this annual FD Awareness Day as we unite to share our progress, achievements, and hope. Today, we especially recognize and support our sons and daughters with FD who are facing endless challenges. We commend the dedicated medical teams in Israel and worldwide, especially Professor Hani Maayan and Dr. Bat-El from Sheba Medical Center, who dedicate their lives to treating patients with boundless devotion. We also remember and praise the tireless researchers seeking a discovery and cure. Finally, we acknowledge the devoted families of our dear patients who make significant sacrifices, even if it is involving many personal compromises. 40 years of dedication, support, and research highlight your unwavering commitment to families coping with FD. The close cooperation between our organizations has been a source of pride and inspiration, highlighting the power of unity in the face of shared challenges. We, the families in Israel, are still coping in the shadow of the war and with concern for the hostages who have not yet returned. We deeply appreciate your immediate and significant support since the war began. In those difficult moments, we felt your warm and unwavering embrace. Against this backdrop, our organization's activities has been significantly reduced this past year. However, I am proud to share that despite these challenges, we have maintained vital activities and continue to support our families. On this festive day, we renew our commitment to our joint struggle. Together, in close cooperation, we will continue to advance research, support families, and raise FD awareness. 40 years is just the beginning. Together, we move towards a more promising future for all our families. We wish all families, wherever they may be, health and peace. Happy FD Awareness Day.
Welcome to the 40th, as you heard, 40th FD Day on 2025. As most of you are aware, or all of you are aware, I cannot move this. Let me see. Okay, as most of you are aware, in last year, in June 20th, 2024, a 15-year-old with FD received the first dose of a drug that corrects the genetic defects. Well, this drug, as you heard, has the potential to slow or stop the progression of the disease. And the drug is an antisense oligonucleotide. It is administered through a spinal injection and is essentially a small piece of RNA that fixes the splicing defect of FD. Now, the trial will last for 2 years, and we almost finished year 1. So today, you are going to hear, I'm sure that everybody has a lot of suspense and anticipation to hear some of the preliminary findings of what we see after 1 year of treatment with this antisense oligonucleotide. So you will be hearing some details, but before that, I want you to hear from some of the crucial people that made this possible. You remember last year we went through the whole history from the description of the disease to the discovery of the gene to every one of the steps. I'm not going to do that again today. I'm just going to tell you that I want you to hear from some of the people, 2 other people particularly, that were crucial in making the last part of this long trip that started decades ago that make this possible. So first, the N. Loren Foundation. The N. Loren Foundation, Sarah Glass, Dr. Sarah Glass, the Chief Operating Officer, Lori Mignon, and Helen Pu are here with us today, and they will tell us about the crucial job or the crucial work of the N. Loren Foundation in making this treatment possible. We will then hear briefly from Adrian Krainer, Dr. Adrian Krainer, and he promised me that he's going to tell us how to make an ASO, how he made an ASO for FD. He only has a few minutes to do it, so take notes. If you want to try this at home, take clear notes. He's the one that made the compound that we are trying now. Then you will hear from Alejandra González Duarte, our doctor that you all know, and she will tell us about what happened with the sensory nerves after 1 year of ASO treatment. This will be followed by, it had to be followed by Carlos Mendoza telling us about what happened with the vision, the retina. He's not able to attend, but I will present his part, and I will also present what happened after 1 year of ASO treatment with muscle coordination. Following that, we are going to cross to behind the curtain, and Mekhi, actually Mechfeld Cupers, who's leaving us to do neuroscience, she is going to tell us what it takes to run a clinical trial, briefly. Then our fantastic nurse practitioners, Kaya and Andriana, Kaya Dalamo and Andriana Barnett, will cross to the patient side, and they will tell us how the patient feels about the clinical trial and how to navigate the journey as a family. So we will have 1 hour. We'll try to show you as much as we can, and you will also hear from the patient himself, and you judge for yourself, and we hope you'll have questions and we'll be able to answer those questions. So without much ado, I would like to introduce Dr. Sarah Glass to tell us about the N. Lawrence Foundation. Sarah, take it away. Is Sarah? Hello?
Okay, how about now? Can you hear me now and see my screen?
Yes, Sarah. Sorry. Go ahead.
Yeah, we're good. Okay. Thank you so much, Dr. Kaufman, for the introduction, and to the community and to Lainey and the team for inviting us here today. I think, you know, as a parent also of a child with a nanorare disease, I want to highlight Dr. Kaufman. I have never seen a physician more enthusiastic about moving a treatment forward for a patient community. I mean, the first time we met Dr. Kaufman, he was like, this is the dream of my career. So he didn't acknowledge himself, obviously, but I think in our brief interactions, he's been really spectacular. So I just want to touch, I know we have 5 minutes, so I'm going to race through, but also try to go as slow as possible for the translation. And Lorem has really had the opportunity and the privilege to work with Dr. Craner, with Drs. Kaufman and Duarte, and many others to get this treatment to your community. And so N-Lorem is a nonprofit foundation. We were established in January of 2020 with the goal of taking antisense technology and moving that technology to be able to help individuals who have disorders that could be treated with this, but ultimately are not part of a community that is large enough to be able to get a commercial drug developed. And so ultimately, N-Lorem's mission was to take this technology, to be able to bring this technology forward. And really interestingly, what we've learned since January of 2020 is that this is changing the way that we actually treat and think about health and disease, especially for that rare disease community. So importantly, and I know Dr. Kaufman, and we'll hear from Adrian Craner coming up next as far as how to design an ASO. I would not recommend doing this at home. Please call us. Please call Dr. Craner. We'd be very happy to help. You know, I think the important thing here is there are 3 decades of experience with antisense technology, 3 decades. And so we understand a lot about this technology. And that's why we're here today, to be able to do this for these very small patient populations. And I think one of the most critical features, you can read here what's on the slide, but ultimately want to focus on the fact that this is supported by the FDA. So in the US, the FDA actually provided 4 guidance documents in January of 2021 to enable organizations like N-Lorem to discover and develop an antisense oligonucleotide all the way through for single patients. What this roadmap describes is actually a path that is abbreviated compared to a commercial program. And that's what makes this possible. And I think that is incredibly exciting. It's very important, and I'll touch on in a minute briefly why we have not moved on beyond the US yet. We're working on it, but that is at the core. Ultimately, the FDA has provided a very specific roadmap. We're trying to work and to see if we can model that roadmap to leverage, you know, and work with other regulatory bodies outside of the US that will enable us to get these treatments to patients outside of the US. So as I said, you know, about 5 years ago, N-Lorem was established. This is just giving you a snapshot of the patient portfolio. including your patient community. And so the way that this ultimately happens is Dr. Kaufman and a physician interested in treating their patient applies to n-Lorem on behalf of their patient. And ultimately, we have processes in place from start to finish to be able to take this patient's mutation, determine amenability, and move it all the way through drug discovery and development to all the way through to clinical treatment. So we've seen a very, very large response, and this really reflects the needs of this patient community. And n-Lorem has grown and continued to scale as a nonprofit, which is of course restricted by funds, as much as we possibly can to enable this. And we're very, very privileged and grateful to have been able to accept a patient in your community to move this drug forward and to be able to leverage some of those nonprofit funds to enable this treatment. So this slide, oh, sorry, we're not on. This slide just shows you briefly, won't get into any detail, but please feel free to reach out afterwards. This is kind of showing you what the process is from drug discovery and development. This is on the very left-hand side is when an individual is diagnosed. Like I said, the physician applies to n-Lorem on behalf of their patient, moving through getting sequencing in cells into ASO design and discovery. And then ultimately, once we've identified a lead, we move into many different activities in parallel. So the goal is to be as high quality and efficient as possible. And so in this particular instance, and this is actually very unique compared to the other 150 programs that we're working on, Dr. Craner, who will speak after me, had published and is a very significant leader in this field and had designed ASOs. And so that was able to accelerate n-Lorem's ability to pick up where he left off, take some of these ASOs, optimize them, and then develop them by screening and moving through the toxicology, manufacturing, sterile fill, et cetera, all the way through to enable us to be able to treat 2 patients today under these authorized research INDs. So as I said before, the FDA guidance is specific, individualized ASOs for patients with debilitating disorders, rare and life-threatening disorders. And so what we're doing is to take and move forward with a single patient, with a single research IND, learning as much as we can, and then considering how can we actually help other patients. And that's really back to that first slide on what are we thinking about with health and disease. We're ultimately enabling a completely new path for drug discovery and development by swinging the needle from common disease all the way to N of 1s. And now the question is, how do we get to what's in between? And that's what we're really focused on now. I think we've essentially scaled and industrialized this process to enable the individualized ASOs. And now we're working with many different elements to get to more patients. So a couple of these, I think it's important, like I said, scaling according to resource, of course, as a nonprofit. And I think Lainey touched on, or someone touched on kind of the environment that we're in. It's very challenging, and acknowledging that challenging environment. How can we leverage every single dollar that we raise to help as many patients as possible? That's our focus of our job every single day. Global expansion is a really critical piece. I just mentioned that the regulatory environment is kind of a question mark. So the way that we're working to prioritize with our very small team is to try to think about what are the critical pieces we need to have in place to make this quick and efficient. Quick is in quotes, but quicker perhaps. The financial operational support. We need a committed physician and a supportive institution. That's a critical piece. And then we can work together, and we're doing that right now with Dr. Kaufman and Dr. Duarte, with patients outside the U.S. and with many others. So we're really trying to work to see how can we move beyond, because it's the first one of anything that's very challenging, and we would imagine those that will come after will not be so difficult to move those treatments forward. So the last couple of things here, like I said, for the U.S. regulatory, the guidance is for N of 1s. Ultimately, we continue to submit these INDs for more patients. So we have for other ASOs, we have INDs that have several patients, and that's really become acceptable. n-Lorem has 30 INDs that have been approved now by the FDA, and we have this very favorable engagement with them. And I think as a nonprofit, this is really allowing us to be very flexible, and our goal is completely aligned. We just want to make a safe and effective drug to help one patient, one after another, and I think the FDA really gets that. We're also focused right now on reimbursement. So acknowledging the financial challenges, not only for n-Lorem, but also for the physicians, for the institutions, and for the patients. So ultimately, we need to be able to get the infrastructure to enable a research IND to become an approved drug that can be reimbursed by payers eventually. And the last two things is really thinking about antisense research. We continue to do a significant amount of antisense research in the upregulation space, in allele selectivity. Our organization is led by Stan Crook, who invented antisense about 35 years ago, so still continues to be very passionate. And the last piece, and Adam Sachs and I chatted even, and I think we continue to acknowledge that the reason that we're here today is through partnerships and through collaborations. And so we're very excited to continue on those things as well. So I won't actually touch on this too much. I know you're going to hear from the clinical teams on specific to this ASO for your community. This is just giving you a brief snapshot of the exceptional data that we're seeing across the portfolio. So this is just showing you what we're seeing. We have actually a pristine safety profile. That's critical, right? We do not want to have any adverse events associated with these ASOs, especially given the abbreviated path, and that's what we're seeing. I think importantly, out of all the patients who are clinically evaluable today, and we have our clinical team here on the line today, so let's led by Lori Mignon, and we have Helen Poo and our newest addition, Serena, who's here as well. So thank you for joining, doing an exceptional job of collecting the clinical data in a very high quality and rigorous way to ensure that we can support the physician's treatment decision. Is there more benefit than risk? And what we're seeing here is that out of 12 patients so far, we're seeing 11 are actually seeing clinically meaningful benefit. And the one that is not had ALS, has ALS and was very severe when they first started. Okay, so I hope I'm in time here. I think, in summary, we're very happy to continue the conversation. And I think what we've shown today is we have industrialized this process. We're really excited about where we are today, especially with the collaboration with Dr. Craner and being able to have this ASO targeting ELP1. So far, the clinical experience does show pristine clinical safety profile and clinical benefit. We have 2 patients on treatment. Initial indications of safety. Again, you'll hear more from your physicians here coming up. And really the focus on the data collection and publication, sharing all of the data, which is so critical. This is going to be important for us. It's important for you. It's important for the broader rare disease community. How are we making sure that everything we learn, good and bad, is shared publicly so we can help more patients more broadly? And the last thing is really that we're committed to pursuing as much treatment as possible for as many patients as we can. And this will be through the US research INDs, expanding one country at a time, as well as commercial partnerships in the future. Excuse me. This last slide just gives you a quick picture of all the partners that we have established over the last 5 years. It's really pretty exceptional when you bring a really compelling story about helping one individual to, say, a drug manufacturer. They don't typically have the ability to interact with our patient communities. And so this has really motivated all of these commercial companies to be able to help us to decrease our costs. So we're down to, 1.3 million per patient. And that's it. I think, again, thank you to all of you for allowing us to be here today. I think we're happy to answer questions either in the Q&A today or follow up as well.
Okay, let me share my presentation. All right, I hope you can hear me now. So I was asked to give a very brief overview, a bit historical about how we made an ASO for FD. And because this is intended to correct a splicing defect, I'm going to very briefly tell you about RNA splicing. I'm sure everybody is quite aware of this. But when genes are turned on in the nucleus of a cell, it means that the information they carry is transcribed to make a messenger RNA. The messenger RNA is then exported to the cytoplasm where it's decoded or translated to make a protein. In 1977, it was discovered that most of our genes have a coding information or exons that is interrupted by non-coding segments or introns. And so before the mRNA can be exported to the cytoplasm, the precursor has to undergo splicing, which means the removal of the introns and the correct joining of the exons. And so later, the machinery that carries out this process was described, and it's called spliceosome. And so I think it's useful to have an analogy, another way for you to think about this. And so we can think of our genome as a library where each gene is a recipe book. And so we have about 20 or 25,000 of these recipe books. One of them tells us how to make ELP1. And we know the language. So each chapter in this book corresponds to an exon, an important part of the recipe to make ELP1. However, the chapters are separated by pages that correspond to introns that are in a different language. And so the recipe does not make any sense unless the spliceosome removes these non-coding pages first. Apologies. And so that's all fine, except that in the case of the ELP1 mutation in FD, the spliceosome gets confused. So occasionally it also removes chapter 20. And when that happens, the recipe no longer makes sense. And so what the ASO we developed intends to do is to remind the spliceosome not to leave out chapter 20. So ASOs are antisense oligonucleotides. And first, I remind you that DNA is a double helix. And so the sequence of building blocks, A, T, G, and C along one strand specify what the sequence of building blocks on the other strand is, because A always pairs with T and G pairs with C. So when the RNA is transcribed, it has the same information as one of the two strands of the DNA, except T is now U, which is a similar building block. And an antisense oligonucleotide is a shorter nucleic acid, but we synthesize it to carry a particular sequence. That sequence dictates what the mRNA target is and exactly where the ASO will bind to that RNA target. So it'll form a double helix also, except that the ASO strand is much shorter. So ASOs are short, synthetic, single-stranded nucleic acids. They base pair to their mRNA targets. As I said, the sequence determines which particular mRNA will bind to and where along the mRNA sequence. And if an ASO binds to an mRNA precursor before it undergoes splicing, then it can affect, in some cases, how splicing occurs. And so the goal here is to restore efficient splicing of exon 20 in ELP1 with the FD mutation. And so although they're similar to RNA and DNA, they also carry special chemical modifications that make them drug-like. So this is another ASO that my lab previously worked on in a close collaboration with Ionis and later with Biogen to develop an ASO for another genetic disease that's more common, spinal muscular atrophy. And so that drug is called Spinraza, and it was approved at the end of 2016. So my lab was involved in this stage of the process, the preclinical development. And you notice in this case, clinical trials were carried out. I mean, these took about 5 years, and they involved hundreds of SMA patients. And so that's a different situation from FD because this is a much more common, albeit rare disease. So the drug is delivered by lumbar puncture to reach cerebrospinal fluid, and that allows the drug to distribute throughout the central nervous system and also beyond, including the peripheral nervous system. So in the case of ELP1 and FD, we have a gene that has 37 exons. And exon 20 is the one that associated with a splice site mutation, so a mutation that affects the recognition of exon 20 by the spliceosome, so that much of the time exon 20 is inappropriately skipped. And so that triggers degradation of the message, and even if the messenger RNA is not degraded, it does not get properly translated. So this is how we search for ASOs that are effective. This is an assay called RT-PCR. And so what we're doing here is we built a mini gene, so a simplified version of ELP1 that only carries 3 exons and 2 introns. We introduce that into a cell line, and together with that, we introduce one ASO at a time. And so each of these lines tells you where these individual ASOs bind along the RNA. In this case, is the last portion of intron 19 preceding exon 20. And so here we have a control where you see the top band means exon 20 is incorporated correctly. And so normally there is no skipping. This is an efficiently recognized exon. But if the mutation is present, we get another band that lacks exon 20. So it's RNA that lacks exon 20. And you can see that the amounts of these bands vary in the presence of individual ASOs. So the ones shown here in green improve a little bit the extent of exon inclusion, and that's what we're looking for. The ones in red make things worse. We don't want those. And the ones in blue have no effect. So if we now look at exon 20, we test additional ASOs. Actually, the majority of these make things worse. And if we now move to intron 20, we have a better situation. We have several ASOs that promote more exon 20 inclusion, the top band. And you notice that all these ASOs are moved along the sequence in steps of 5 nucleotides, which gives us a way to rapidly survey the sequence space. And so then we're interested in this region where the effects are stronger. Now we could do a higher resolution screen. So now moving ASOs in steps of 1 nucleotide, and we can also vary their length. And this particular set are 20 nucleotides long. And so the best one out of this screen is this that binds from position 7 through position 26, and it gives us 96% exon 7 inclusion, almost as good as a wild type gene. So that's in these cell lines, which are not particularly relevant, but they're easy to screen. We also then moved on to patient skin fibroblasts. And so you can see a normal fibroblast, one from an FD patient. So there is this extra band, exon 20 skipping, but in the presence of the lead antisense oligo, we have higher levels of exon inclusion. And this is an assay to look at protein called the Western blot. And so we see some protein that's correctly produced, but in the presence of the ASO, the intensity is greater. That means the levels are higher. And so then I don't have time to, but we then proceeded to test transgenic mice that carry the human gene with a mutation that were built by Sue Slaugenhaupt and colleagues. And we could show that the ASO worked in that case as well. So importantly, we followed pretty much the same procedure as for Spinraza. So all the chemical modifications are the same, and these 2 oligos, the FD ASO is 2 nucleotides longer, and obviously it has a different sequence because it targets a different mRNA. But we think its properties and safety should be very similar. So we published this work in 2018, and so this was largely carried out by 3 very talented students who were in my lab consecutively, and other members of the lab, and then Frank Rigo and Frank Bennett at Ionis. And but then we got to the point where Ionis felt that they couldn't pursue this development commercially because insufficient number of patients. And so this was very frustrating. So a crucial development took place the following year, and this is work by Tim Yu at Boston Children's Hospital on a different disease. But he showed, following a very similar path, that he could develop an ASO for a single patient who had a particular mutation in a relevant gene for this disease, and then persuaded the FDA to allow a study in that one patient. And so that opened a streamlined path for ASO development. And the following year, the Anne Loren Foundation started, and so this was crucial for the work to proceed. And Dr. Kaufman and I had discussions early on with Anne Loren. did our best to persuade them, and were successful to persuade them that they should pay attention to this disease, even though it's an N of 300, not an N of 1, but we have to start somewhere. And so fortunately, then Anne Lorem conducted a very professional, cutting-edge study of the safety of the ASO by conducting the required toxicology studies. And so I'm very grateful to the teams at Anne Lorem and to the clinical team and Dr. Kaufman's group as well. Our earlier collaboration with Ionis, Dr. Saugenhaupt and Pickle, who provided transgenic mice, Greta Dornberg, who's a patient advocate and a mother of an FD patient, and our sources of support. And thank you very much, and I'll be happy to entertain questions later at the panel. Thank you.
Good morning. I am Dr. Alejandra González Duarte from the Davis Autonomia Center. Today, I'll share the outcomes of a 9-month study using an antisense oligonucleotide, NL-IKBK001, specifically designed for familial disability. This work reflects the dedication of a multidisciplinary team. It began with the vision of Dr. Kaufman, who brought together the scientific brilliance of Dr. Greiner and the wavering support of two remarkable foundations, Anne Lorem and the FD Foundation. To scientists, clinicians, nurses, technicians, and most importantly, to the participant and their family, this has truly been a collective effort, and thank you all for it. To understand the rationale behind the study, we first need to follow the journey of the ASO. It begins with a lumbar puncture, a procedure that delivers the ASO directly into the spinal fluid. From there, the medication travels up the spinal canal to reach the areas where most of the neuronal cell bodies reside. In particular, the ASO is designated to target the dorsal root ganglia, where many sensory neurons are located. Once inside the neuron, the ASO corrects the splicing error, enabling the production of more functional L1 protein, which is essential for a proper neuron function and survival. This slide summarizes the full protocol timeline for this participant in the ASO study. The process began with flight and hotel accommodations arranged in advance. Upon arrival to NYU, participant underwent a series of clinical assessments, both on-site and off-site. Following this evaluation, he was admitted to NYU and underwent a lumbar puncture on the operating room. Then he remained under 23-hour observation, during which vital signs and neurological status were closely monitored. Once cleared, the participant was discharged and returned home by flight. The primary goal of the study was to evaluate safety. The secondary objectives focus on sensory function, which we'll explore in detail in the following slides. The first and most important objective of the study was to assess safety. I'm happy to report that the treatment was very well tolerated. There were 2 instances of mild back pain following the infusion. Both were short-lived, resolved with Tylenol, and did not require any further intervention. Symptoms disappeared in less than 24 hours. Importantly, there were no serious adverse events, no complications from the lumbar puncture, and no unexpected side effects. Then we measured the L1 in blood. Levels were undetectable at both the pre-dose and at baseline. After treatment, they rose up to 14 picograms milliliter at month 2 and to 24 picograms milliliter at month 4. This increase confirms target engagement. This slide shows results from quantitative sensory testing measuring the foot, which is a test used to measure the minimum change in temperature and vibration that a person can detect. On the left, there is the cold sensation threshold graph. Initially, the patient was unable to sense cold, and the device reached its minimum setting of 0 centigrades without a response. At 9 months, the patient was able to detect cold around 9 centigrades, indicating an improvement in cold sensitivity. In the middle, there's the warmth detection threshold graph. This is a slight improvement at 9 months, meaning that the participant was able to detect warmth at a lower temperature than at baseline, again suggesting enhanced small nerve fiber function. On the far right, you can find the vibration detection threshold, which reflects a larger nerve function. The threshold decreased from 20 Hz to 10 Hz at 9 months, meaning that the participant was able to detect vibration at a lower frequency. In this slide, we summarize the findings of the nerve conduction studies, focusing on sensory nerve action potential, or SNAPs. The graph in the box shows a SNAP amplitude, that is, the size of the electrical signal produced when the sensory nerve is stimulated. We measure the SNAPs in 3 nerves: right median, right ulnar, and the right sural nerve. You will notice that in 2 of the nerves, the sensory amplitude increased at 9 months compared to baseline, while it remained stable in the 3rd. Interestingly, these changes were not observed when assessing motor function action potential, which are typically unaffected in familial dysautonomia. Finally, as a marker of neuronal degeneration, we measured neurofilament light chain, or NFL. The nerve fiber is made up to both light and chain heavy filaments, and the light chain is a well-established biomarker of axonal injury widely used across many neurodegenerative conditions. Using a high-sensitivity Quanterix assay, we observed a decline in blood NFL levels from 3.4 to 2.1, just 2 months after treatment. This reduction was consistent with levels remaining low at the 4th month mark. Now, let's shift to measures of body stability. Using wearable sensors in the mobility lab, we assess body sway, a natural movement that reflects how the body maintains balance. The system tracks movement in 3 directions: forward, backward, side to side, and rotational shifts. Together, these movements trace a circular area that represents how much the body is swaying. A smaller circular area means that the person is moving less. Then, the movements are translated into angular displacements, which then now Now let's look at another important mobility measure, the 360-degree turn. While spinning, we measure 2 things: turn duration, or how long it takes to complete a full spin, and turn speed, or how fast that turn is performed. On the left, you can see that the turn duration increased from pre-dose to baseline, indicating a slower movement. But then it improved at 9 months, suggesting a better control and quicker execution. On the right, we see turn speed. After an initial decline at baseline, speed improved significantly by 9 months, reaching a level even faster than pre-dose. Now, turning to gait, we assess 2 fundamental components: cadence, or the steps per minute, and speed, or how fast this person is walking. On the left, you can see that the cadence declined from pre-dose to baseline, likely reflecting reduced coordination or confidence. But by month 9, there was a clear recovery, with the participant regaining a more rhythmic and steady pace. On the right, gait speed also dropped at baseline, but showed a notable improvement at month 9. While not back to full baseline levels, the participant was walking faster and more fluidly than before the treatment began. Here, we are looking at the skin biopsy, which is used to measure intraepidermal nerve fiber density, a direct marker of the nerve fiber integrity in the skin. The procedure involves a very small punch biopsy about the size of a pencil eraser taken from the distal leg, approximately 10 centimeters above the ankle as shown in the diagram. The tissue was processed and stained using PGP 9.5, a pan-neuronal marker that marks the nerve fibers glow green under fluorescent microscopy. What you're seeing on the right are the actual images of the patient's nerve fibers in the dermis. At baseline, nerve fiber density was extremely low. just 0.2 fibers per millimeter, far below the reference value of 9.1. In the below image, you see at 9 months that there was a marked increase to 2.1 fibers per millimeter, a 10-fold improvement in visible nerve fibers within the skin. We also perform a second skin biopsy, this time at the distal thigh, which is a more proximal site, about 10 centimeters above the knee. On the right side, you can see the baseline image with nerve fiber density stained in green that was markedly reduced, measuring 3.5 fibers per millimeter, which is way below the normal threshold of 12.7. Now, looking at the 9-month image below, we see a striking regeneration of small fibers, with nerve fiber density increasing to 14.2 fibers, a value that is now within the normal range. These results provide compelling evidence of nerve regeneration at the proximal side of the skin. Using a standardized scale to assess activities of daily living, we observe improvements in functional tasks such as reading, moving a chair, washing dishes, traveling or using public transportation, walking up to 1 kilometer, carrying heavy objects, and even running. To conclude, after 9 months of intrathecal administration of NL-IKBK001, an antisense oligonucleotide specifically designed for familial dysautonomia, no adverse events were reported. We observed a range of positive biological changes, including increasing blood L1 levels, confirming the molecular target engagement, improved temperature and vibration thresholds in the foot, indicating sensory nerve recovery, increased snap amplitudes and nerve conduction studies, reflecting possible axonal improvement, reduced blood neurofilament light chain, a marker of neuronal injury, and importantly, evidence of reinnervation in the skin with intraepidermal nerve fiber density reaching normal levels in the distal thigh and showing a marked increase in the distal leg. Parallel, we documented several clinically meaningful improvements, including body sway with the eyes closed, faster gait speed and improved cadence, and greater functional independence as captured by improvements in activities of daily living on the Rhodes scale. However, important questions remain. Will these improvements continue or persist over time? Are the effects reproducible across a broader and more diverse population? And can this therapy offer similar benefits in older individuals? These are the next steps that will guide future research and ultimately determine the long-term potential of these treatments. Thank you.
Hi everyone, I'm Meki and I'm going to take you behind the curtain to what it's like to run a clinical trial. So our trial takes place between New York and Miami. We're really grateful to have Dr. Mendoza on board helping us with the OCTs in Miami, but for this talk I want to focus on New York. So we use 4 NYU locations. We have our office and the operating room in the main campus. Down in Bellevue, we have the CTSI Pharmacy and CTSI. So quick side note, the CTSI, or Clinical and Translational Science Institute, is an NIH-funded research program that helps with clinical trials, and they've been unbelievably important for this trial as they help pre-op, they're in the operating room with us, and they also help with the 24-hour and 6-hour monitoring post-operating. We also have the MRI facility and the Nerve Conduction Velocity Testing Center. But as a research coordinator, I'm really focused on timing. And so for me, it's really important to know exactly how long everything is going to take. But here I want to focus on the 9 minutes it takes to get from pharmacy to the operating room. Okay. So taking a quick step back, our medication, the NL-IKBK001, gets manufactured and then shipped to the Bellevue CTSI Pharmacy. In shipping, we have to make sure that the medication is temperature controlled, so we want to maintain a temperature below 8 degrees Celsius, but we also want to make sure we know exactly what the temperature is throughout the whole temperature, so it's closely temperature controlled within. Once it safely arrives at CTSI, it is then stored in a refrigerator and protected from light, and the temperature is monitored daily. Finally, when we're ready for an infusion, we ask the CTSI pharmacist to prepare the medication for us. And within preparing this, it starts our 4-hour timer. So this means that we have 4 hours to get the medication from preparation into the patient. So the first step in this preparation is a 30-minute rest. So by the time we're ready to actually transport the medication to the operating room, we have 3.5 hours. And here's where that 9 minutes comes in handy. So in that 9 minutes, the medication is actually going outside. So that's really important because in New York, it could be 15 degrees in the winter, 100 degrees in the summer, but we want to make sure that that medication isn't reaching any of these extremes. So in our 9-minute walk, we're transporting it in a cooler and we're getting it to the operating room. But that means by the time we actually make it to the operating room, we have 3.3 hours until that medication has to be in the patient. So that's about 3 hours and 20 minutes. In that 3 hours and 20 minutes, we need to wheel the patient to the operating room because we can't go in the room without the medication. We need to put the patient under anesthesia, and we need to start a lumbar puncture where we actually collect 20 milliliters of CSF to send to the lab, and then we can begin to administer the medication. So we've been really lucky that we've been able to make it every time, but that doesn't mean we haven't faced a few complications. So some of the complications we've run into. Before our first infusion, the medication actually never arrived at the pharmacy. So the day before the medication was supposed to arrive, we tracked it down to a facility on the west side where Margarita and I jumped on our bikes. We picked up the medication and hand delivered it to the CTSI pharmacy so it was ready for infusion the next day. We've had issues with the laboratory where they've lost our lab samples. So before you can actually do a lumbar puncture, there's some very important lab tests we have to check. And the morning of, we were going to check those results and the labs just were gone. They had lost the samples. So that we had to recollect the samples that morning and have them rerun. We had one time when the medication arrived at the CTSI pharmacy, but during shipment, it had gone briefly out of range, which meant we had to contact the facility and the manufacturer and the medical monitor just to make sure the medication was still safe to use. Luckily, it was okay and everything went well. Operating room, every once in a while, there's an emergency that kind of bumps you from your operating room slot. This has happened, and if you're within the 4-hour window where the medication's been already prepared, it can get a bit close, but luckily the operating room staff have been extremely helpful in making sure we get in the operating room and we're ready to go with our medication before our 4-hour window's over. And then lastly, just hospital admissions. I know we've all been there and struggled with them a little bit, but just running a trial using an inpatient facility can be a little challenging, but luckily, we've made it through all these issues, and it just really shows that it does take an entire village to run a clinical trial, and we're so thankful for all of our collaborators and everyone who works with us to make sure these trials run smoothly. So I just want to say thank you to everyone.
Hello and welcome everyone. My name is Andriana.
And my name's Kaya. We're the nurse practitioners of the NYU Dysautonomia Center.
Today, we are honored to share with you a series of interviews with patients and their families.
To respect their privacy and maintain confidentiality, we'll be presenting these interviews in a completely anonymous format. We've utilized avatars and alternate voices to convey their words to ensure their identity remains protected while allowing them to share their valuable insights and experiences.
Thank you for joining us. So I have a few questions for you about this genetic therapy. Are you ready?
Yes.
Okay, so what is familial dysautonomia and how does it affect your child?
So for our child, it mainly affects blood pressure and heart rate regulation, respiratory issues, the lack of tear production, and swallowing. So it makes things a little harder sometimes.
Your child is receiving a new treatment for FD called genetic modifying therapy. Can you tell me what it's supposed to do for FD?
My understanding is that the therapy may prevent progression in my child's disorder. So my child could see things like worsening vision, worsening gait, or not walking as well. And hopefully the genetic therapy will at least prevent that from happening and keep them where they are at this time, and potentially also get to see if things improve.
How did you react when you found out your child will be receiving therapy for FD?
We have been waiting for this since the day they were diagnosed.
And what were you most excited about?
Well, we were just very excited for them, you know? I mean, they have a heart of gold and they just have a lot of love in their heart and deserve the best in life. And we wanted to be able to give them that.
Just the possibility for them to live as much of, now I don't like to say the word normal, but as much of a typical life as possible.
And what were you most nervous about?
All of the unknowns and potential side effects.
What are you most nervous about?
Well, we worry about side effects. You always worry about the risks of every procedure, but there are risks every day in life, right? So I would say we're not worried about much.
Are you more comfortable with the infusions now?
Yes, I mean, we've seen the results that give us hope and promise for the rest of the gene therapy. And being able to see these results, especially when you're in the weeds and you can see the difference from the treatment of only 9 months, is very positive and hopeful.
Your child has now been receiving genetic modifying therapy for almost a year. Did you notice any changes in their symptoms after the first dose or continued changes since starting?
We're very pleased by the data that's being shown, and I have a friend who swears that my child's gait has absolutely improved.
Yeah, I mean, it seems like their physical ability to do things is better. Even persevering through unpreferred activities seems to have gotten better. Their ability, their gait, and their focus and speed and ability to do more difficult physical tasks seems to have improved.
That's amazing.
Are they better able to participate in activities or hobbies?
They have definitely matured over the last year. I guess for me, it's hard to say, is that a result of the genetic therapy or is it because they're getting older? But it will be wonderful if the gene therapy had something to do with that.
And do you think you've seen any side effects from treatment?
No, not really. No, we haven't seen any.
Do you think they had any side effects from the treatment?
No, not at all.
And what's the thing you're most hopeful for to eventually happen with continued treatment?
I would love for continued treatment to make an impact on crises symptoms, because I do still think that at this point in time, that makes the most impact on their quality of life. And then we think we're seeing an increase in messaging to the brain, and it's exciting to see where that might go. Like my child will say, "Oh, I don't think that I would have known that was so cold before."
Hopefully my child has this close to normal quality of life. I'm hoping that it eradicates the whole disease.
Now, how do you feel about their future or your family's future?
I can't even imagine the possibilities now. I feel like anything can happen and nothing can stop them.
Absolutely. It's made a huge change. I mean, we've remained optimistic throughout the whole process of diagnosis to where we are right now. But now there's a light at the end of the tunnel, and it seems like it's getting a little closer.
I would say we have more hope than we did for the possibility of a more independent life than we were planning for our child.
Hi.
Hi.
Do you know why you're here today?
Yeah, I'm getting my treatment for FD.
Yeah. And what is the medication supposed to do for you?
Make FD less severe for me.
Yeah. And how did you react when you found out that you would be getting this genetic therapy?
Excited.
And what are you most excited about?
Just getting it.
And what are you most hopeful for?
Drinking water by mouth.
What are you most nervous about?
Nothing.
Wow, you're so brave.
Yeah.
What are you looking forward to?
Going to the snow. I want to go up into the mountains into the snow.
Wow, to go up into the snow, that's really good. Well, I hope that can happen for you. We're looking forward to the good changes coming for you. Very excited.
Yeah, thank you. You're getting a new treatment for FD. Can you tell me what it's supposed to do?
To be able to feel more?
That's right. You've been receiving genetic modifying therapy for almost a year now. Did you feel any different after the first dose, or do you have any continued changes since starting?
Well, I feel more like sometimes I think I feel heat, maybe in my mouth while eating. And I used to not feel my injections, and now I can.
Oh, wow. That's pretty cool. Are you better able to participate in any activities or hobbies that you like?
Well, just 1 month ago, I ran a mile with my friend. This was the first time I've run for so long in my life.
Wow, that's amazing.
Well, thanks for speaking with me today.
You're welcome.
Bye.
Bye.
In summary, genetic therapy is bringing new hope to families with FD.
And there's already positive feedback from a family about perceived real-life benefits.
This advancement may not only improve patient outcomes, but also enhance quality of life.
So, as we continue to make progress, we remain very hopeful about the future impact of genetic therapy for FD.
Of course, is the most interesting and emotionally loaded, exactly what happened with the patient. I was supposed to present this first. I will show it to you. What I will show you is what happened with vision and muscle coordination after 1 year of treatment. In reality, Alejandra showed you 9 months because 1 year is in a few days. The 1 year has not occurred. So I'm calling it 1 year, but it's less, and the data, we just got the data a few days ago. So I will, as I mentioned, I will talk about vision and muscle coordination after treatment. You're all aware that in individuals with FD, both vision and motor coordination or muscle coordination are preserved early in life, but progressively deteriorate with age. That's why we took those two problems, the vision problem and the coordination problem, as the outcome that we could measure of this treatment, because we thought that many of the other features were not going to change. So, because again, as you're aware, there are many deficits. People with FD are born and they remain and do not worsen too much. Others, like vision and coordination, are relatively good or quite good at birth, and then they progressively deteriorate or get worse. So let me tell you about vision. The progressive loss of vision that occurs in FD, one of the main culprits is the retina. Patients have an optic neuropathy with degeneration of the retinal ganglion cells. Now, as you know, and I'll make it very short, the retina shown here, I don't know if you see my arrow, shown here is a thin layer of photoreceptors that are in the back of the eye. Now, these photoreceptors, what they do is they transform light into electrical signals. Those electrical signals are transported through the optic nerve to the back of the brain, the occipital cortex, and the images are formed there. Now, something that happens in FD is that, these cells, many of the cells of the retina, deteriorate over time, and that is one of the main reasons for the visual loss. Now, using a device, a little machine called ocular coherence tomography, or OCT, that creates a very precise 3D image of the retina when the person being tested just looks into the machine. And with that three-dimensional reconstruction, we can accurately measure the thickness of each of the layers of the retina. Here you see a patient looking into the machine, and this in the screen is a reconstruction of the retinal layers. Now, this shows you, this is an image from an OCT. You see here all the layers, and this one that I put the blue arrow, this is the retinal nerve fiber layer, and this is one we measure in detail. So over a decade ago, actually like 14 years ago, we first measured the thickness of the retina in 50 people with FD of different ages. And as you see, here is a 9-year-old, a 28-year-old, and a 39-year-old. What you see, okay, these images are a reconstruction of the retina, and the red areas show areas of the retina that are thinner than normal, that are below normal. And you see in a 9-year-old is only this part, 28 is the red is more, and at 39 is even more. What you see here on the right side of the slide is the tight relationship between the thickness of that retinal nerve fiber layer and the age, with older people having thinner retinas in the retinal nerve fiber layer than younger ones. So we began using OCT. This was a cross-sectional study, but we began using OCT to measure the retina at every visit. And it became quickly clear that retinal thickness declined progressively over time in all patients. So with that, we studied over 130 patients, and not only once, but we followed them over time. And what you see here is a summary of this study. All this is published and shows that here is the age of the patient, this is the retinal nerve fiber layer, and this blue line, each dot is a measurement, and this blue line shows you how the thickness goes down progressively over time. Since age, the youngest patients are around 5 years old, and this goes progressively down, and then it plateaus. So with this data, we were able to have a map, like a roadmap, of what happens with the retina over time, and we could model, we could try to see, that's what the FDA and what we wanted, we could model what we could expect of a drug that would stop the decline, or would stop it, or maybe even reverse it, or just stop it. So what I'm showing you here is a graph, right, that shows from age 5 to 25, the percent change, to be able to compare. Now I'm giving you percent change, and as you see, it goes progressively down. I'm marking here 15 years old because that's when we started treating the first patient. So what you see here now, if you bear with me, is a model, a projection of what would happen if the ASO had 30%, meaning if it would slow progression by 30%, it is first line. If it would do it by 60%, this is the line we would expect, meaning, this is the line you would expect. It will be, again, the slope, it will decrease, but it will not decrease as with no treatment. And the upper line will be 90% improvement. So this is what we were modeling for years, hoping for a drug and trying to understand what the drug could do. So what happened after 1 year of ASO treatment? I got this, the last point, of course, a few days ago, because we did this measurement at Bascom Palmer. So this is what happened. I would like to have some music to show you, but I don't, so you just have to imagine the trumpet in your head. And here in red, I added, just for 1 year, what was the change in retinal nerve fiber layer in the patient, right? So clearly, there was not only lack of decrease, there was actually a small, very small increase of the retinal nerve fiber layer. So in conclusion, for vision, after 1 year of treatment, the expected thinning in patient 1, that we know it thins every year, did not occur. On the other hand, and I didn't show you, but I'm telling you now, the visual acuity and the color vision remain stable. They didn't worsen. So, of course, we're very encouraged by these results, but it is too early to predict whether this effect of the ASO will be persistent or reproducible. So let me briefly tell you about muscle coordination. You know that in people with FD, there is a progressive loss of muscle coordination. This is known. This condition has the Greek word of ataxia, which essentially means lack of coordination. This ataxia is due to impaired proprioception. This difficult word, proprioception, is the sense, is the ability of the brain to detect where the limbs, the arms and the legs are in space without even looking at them. Now, this ability to sense where our limbs are in space is dependent on peripheral nerves. peripheral sensory nerves, which, as you know, degenerate in FD. So this progressive problem, this progressive difficulty with muscle coordination or ataxia is very evident by the fact that, as you all know, many people with FD need to use walking aids when they get older, and usually in the second and third decade, as you've seen the graphs before, late teens and even older, many patients need walking aids, and when they are older, some may even need wheelchairs occasionally. So to measure the change, to measure this progression or worsening of the ataxia, we use something called the BARS, or the Brief Ataxia Rating Scale. This is a very simple rating scale that has been used for many years, and it assesses gait, that maneuver that Alejandra showed you, finger to nose, right, moving like that, or heel to shin, and speech, and each of them is rated, and the total score is 20. So the same thing I showed you with the retinal nerve fiber layer getting progressively thinner, the ataxia, or the rating of the ataxia, these bars, this Brief Ataxia Rating Scale, gets progressively worse. As you see here, it increases, right? And this shows the change in points, considering 0, how in time, let's see, in 1 year, it worsens around 2 points, and in 3 years is almost 5 points. These are what's called the confidence intervals. So this is, again, with no treatment and the known progression. So doing the same modeling I showed you before, we said, okay, and this slide is actually from many years ago, if we had a drug that could delay progression, it would go like this, right? It would worsen less. If we have a drug that would stop progression, you take the drug, your ataxia doesn't worsen anymore, it will be there. So what happened after 1 year of ASO treatment? Again, I don't have the music, but hear the music, the trumpets. This is what happened with the patient, and actually in 1 year, not only there was no progression, there is actually a 3-point improvement, which of course we were not expecting in the Brief Ataxia Rating Scale. So in conclusion, similar to the other, after 1 year of treatment, the expected worsening of the rating scale did not occur. Balance and gait remained stable or even improved, as Alejandra showed you. So, of course, we are extremely encouraged, but it is too early to predict whether this effect of the ASO will be persistent. So, thank you very much. I think, the program is a little, but I was now the last speaker. Look, I hope, let me wrap this up very, very briefly. If you thought that what Adrian showed you and explained to you of putting a little, first to find that actual sequence of that little piece of mRNA called the ASO, then not only it goes in, it goes to every damn neuron, goes inside. And when it gets inside, it goes to the nucleus. And in the nucleus, it just knows exactly what to do and joins the mRNA. Now, if you think that a drone is a big deal going out and coming to the base, just imagine, to me, it's still science fiction. I see it and I have, now, that is science fiction. What we are seeing with the patient, and we hope is reproducible, is not science fiction, is a miracle, right? So we hope that this is a real miracle, that we are be able to reproduce it and continue. Again, we cannot be happier. These results were beyond our expectations, and I'm delighted now to leave the podium to Francis Lefcourt, who's the head of our advisory board, and more than that, she's not only a friend, but a constant intellectual stimulation, excitement, and new ideas. So, Francis, we couldn't do it without you. Without you and Sue and Elisabetta and the rest, we couldn't do this. Francis, thank you so much.
Thank you. I hope everybody can hear me okay. I'm just blown away by this presentation. I mean, the thanks go to you, Dr. Kaufman, Dr. Duarte, Dr. Craner. This is really a miracle. I mean, as a neuroscientist, to see nerves regrow, especially in the retina, which is the brain. I mean, that's amazing. So it might take me a while to come down here, but anyway, it's a pleasure to be here with all of you. It's, as you've just seen, this is an incredible time to be doing FD research. I hope our government is listening. The head of NIH is listening to this presentation, so they realize the import of this work and why we have to, as a society, fund research, because it leads to days like this and miracles like this. So anyway, the great news is not only do we have this exciting ASO development, but we have other great promising therapeutics in the pipeline. And more is always better. And so it's a pleasure. I'm going to introduce, could I have the next slide, please? First of all, before I introduce the speakers, I just want to give a shout out to the wonderful people I work with. First of all, Adrian Gilbert, who couldn't join us in the presentations today, but he's a critical part of our team and a great chemist, knows pharma, and has been really instrumental in helping us get to this day. With his absence, Adam Sachs has stepped in, and Adam's going to tell you about all the exciting developments with Tikkun. And this community is amazing. I mean, Dr. Marini, Dr. Slagenhaupt, Dr. Craner, everybody, Carlos. So anyway, the next presentations, as Dr. Kaufman mentioned, the goal for all of us is to increase levels of the ELP1 or ICAP protein. It has two names. And especially want to increase levels of this protein in neurons. So there's different ways to do that. One is with antisense oligos that you've just heard about. Another way is with CRISPRs. You might have heard of CRISPRs. They're in the news. In general, it's called gene editing. And we have a group now, Dr. Elisabetta Marini, Cristiano Alves, and Dr. Slabenhout, who are got a early career award with courtesy and generosity of the Kopelman Foundation through the Claire and Philip Wexler Research Fund. Thank you so much for your generosity. So Dr. Marini is going to give a presentation on gene editing. Then we are also doing a gene therapy project specifically targeting the retina to increase the survival of neurons in the retina. And Dr. Anil Chakuri has taken over that project. It was started in my lab, but now I retired, and now Dr. Chakuri is leading the effort, and it's also helped in its development with Tikkun Therapeutics. And Dr. Chakuri also received a Young Investigator grant from the Wexler Research Fund and the Kopelman Foundation. And again, thank you so much. We're then going to hear a presentation from Dr. Slagenhout on small splicing molecules. You know, she's been working for a while on these molecules, and they're proving very, very exciting and promising. It's another mechanism for increasing production of a normal mRNA, that exon 20 we want included, as Dr. Craner described. And then lastly, Dr. Miguel Weil from Tel Aviv University has got a different strategy for increasing the function of neurons, and he's going to present. And then finally, we're going to turn this over to Adam Sachs, who's the CEO of Tikkun, and he'll tell you about our efforts at Tikkun to help move all of these therapeutics along. So thank you very much to all of you, and let's all enjoy this day.
Good morning, everyone. It's such a great pleasure today to be here and presenting our work on developing a novel gene editing therapeutic strategy to correct the LP1 splicing defect that is responsible of FD. So as we all know, FD is caused by a specific single change in the LP1 lead, and this change lead to low expression of the LP1, particularly in the brain and in the nervous system. So what we are aiming to do is to develop a specific gene editing approach that by restoring the normal letter in the LP1 gene, we can correct the genetic defect of the disease and restore the normal expression of ELP1, particularly in the brain and in the rest of the nervous system. So our approach is known as cytosine base editing. So base editor are tools that are used to make very precise changes into the DNA. They are so precise they can change just a specific letter in your in the genetic code. And base editor work like a GPS guided pencil. One part of the tool that is known as guide RNA guide the base editor exactly in the spot where you have to make the change, and the other part, base editor, make this small change to fix the single letter in the code that is specifically in this case is wrong in the LP1 gene. So what are the advantages of a gene editing approach for FD? So first of all, this is a one-time treatment. So you do it once and never again. So you can permanently correct the underlying genetic cause of the disease with a single intervention. Another positive aspect of this intervention that you can preserve the natural gene regulation. So by fixing the mutation in its original location, you can ensure that the correct gene is expressed at the natural and healthy level in your body. So these are both very important aspect of why a gene editing approach can be advantageous compared with the current available other therapeutic intervention for FD. So in order to develop a base editor for FD, we have to optimize and test a combination of guide RNA and base editor in order to be very specific and precise in correct the wrong letter that is in the LP1 gene, but do not change the surrounding other letter that are in this gene. So we tested many combinations of both guide RNA and base editor, and we came up with a combination that is highly precise in correcting the letter that is wrong in FD. And then we wanted to see if our approach is able to, in fact, restore the normal function in FD neuron. So what we did, we use AAV2 that are harmless viruses that are used in molecular biology to specifically deliver this tool inside the cells. And then we deliver this in FD sympathetic neuron, and then we look and see if in fact this tool works in neuron. And this graph is telling us that our approach precisely corrects the letter that is wrong in the FD, but does not correct the surrounding letter. And the other important aspect is that we look at the function of the neuron. So control neuron, they normally do not fire much. Their activity is very low. What happens is in FD is that the sympathetic neuron, they tend to be very active compared with a control neuron. And so as you can see, untreated neuron, untreated FD neuron tend to have way higher activity compared to a control neuron. But after we edit the ELP1 wrong letter using our gene editing intervention, we are able to kind of restore the normal function. So the function of the neuron go back to the normal control activity. And this is a great news because this means that our tool and our gene editing approach work in FD neurons. As the next step, we wanted to see if in an in vivo system, we are able to successfully deliver our tool and make it go exactly where it needs to go to do the correction. So again, we use viruses that are harmless to deliver the tool into a FD paths, and we injected this intravenous so that the tools could travel throughout the entire body and so reach every single cells. And then we look to see if our gene editing approach was able to restore the normal ELP1 expression. So this is a gel that shows that in a mouse brain that is untreated, normally the expression of the functional ELP1 is very low due to the changes of this specific letter in the ELP1 gene. But after we correct this letter, we are able to increase the expression of the functional ELP1. And this graph shows that we are able to increase significantly the expression of the functional ELP1 gene in the brain. And this is a great news because meaning that our tool is able to reach the brain, correct the change, and restore functional ELP1 in the brain. Similarly, we saw exactly the same thing in the liver. So normally the expression of ELP1 is very low, but after we treat the mice, we restore very high level of functional ELP1 transcript. And another important aspect is that we have to make sure that our strategy is very precise. So we only correct the wrong letter in the ELP1 gene, but we do not edit anywhere else in the genome. So we test our approach and in FD line, in neuron and another line, and we really wanted to make sure that our approach only change the letter that is wrong in ELP1, but everything else is maintained normal. And we were able, very impressed to see that in fact our base editing approach is highly precise, and we did not detect any unwanted change everywhere else in the genome. So right now, what we are working on is to see if our strategy can work in the eyes of our mice. So we are trying to deliver this base editor specifically in the eyes using, again, these harmless viruses. And we want to do this. We use FD mice that have the disease, and they also have eye disease, so they also have retinal degeneration. And by delivering this tool in the eye, we wanted to see if we are successfully in rescuing vision in these mice. And this project is in collaboration with Cristiano Alves, that is an expert on gene editing. And I just wanted to highlight that this has been funded by the National Eye Institute, and also this work has been funded also by the FD Foundation, and we are very grateful for the support from the FD Foundation for this specific work on the eye. Another project that we are working on right now is to see if a combinatorial treatment using both the compound that Sue is developing, and she's going to talk about it later today, and our gene editing approach, if by combining these two strategies, we are obtaining even better result in alleviating the symptom of the disease. And so we are planning to deliver the compound using a specially formulated food for the mice, and we are delivering our gene editing tool by still using these harmless viruses. And we wanted to deliver both the gene editing directly into the brain, but also intravenous, systemically everywhere in the body, to see if, in fact, by combining the gene editing and the compound that Sue is developing, we are able to obtain even better result in alleviating the symptom of the disease. This work has been described in a R01 grant that has been resubmitted to NIH on March and is currently under review. And hopefully we can all back from good news from NIH soon. So in conclusion, I show you that our gene editing approach is very efficient and precise in correcting the splicing changes that is responsible of FD. Our strategy restores normal expression of the LP1 gene and is really much working in restoring the functional activity in FD sympathetic neuron. Our gene editing treatment rescued the splicing defect in mouse, and this is a great news because meaning that has a strong therapeutic potential. And what we are working right now in the lab is trying to optimize this engineering strategy to improve the efficiency and precision of our gene editing approach. We are trying to design an editing strategy to specifically improve vision and target the eye disease in FD. And right now we are also trying to assess if by combining the compound that Sue is developing with our gene editing approach, we can achieve even better result in alleviating the disease symptom. So with this, I want to thank all of you for listening to me and for your attention. I want specifically thank Cristiano Alves, that is the collaborator and expert in gene editing and is working with me on this project. And also I want to thank Nadia Zedner, that is testing our gene editing approach in Neuron, and of course Suz Lognab, that is my mentor, and all the people in the lab. And and again, I want to thank one more time the FD Foundation for supporting this work. Thank you all for your attention.
Hello, everyone. My name is Anil Chakori. I'm a faculty member at Scape and Sci Research Institute of Massa, India. Thank you for giving me the opportunity to present my work today based on the gene augmentation therapy to restore vision loss and familial dystonia. I don't want to go deep into the introduction because the previous speakers actually have did a great job introducing the molecular pathology of the FD. But to briefly recap and set the stage for the future work, FD is caused by a splice site mutation in a gene called ALK1, which leads to skipping of exon 20 and skipping of exon 20 and thereby leading to significant reduction of ELP1 protein, predominantly in the nervous system. ELP1 is a scaffolding protein which plays a very important role in transcriptional elongation, tRNA modification, and cytoskeletal remodeling. And one of the important aspects of the disease, as we know, is the differential splicing effect of the ELP1 with the splice site mutation, where there is a reduced normal transcript, ELP1 normal transcript in the central nervous system compared to the other tissues, non-neuronal tissues. I probably don't need to explain much, but patients with FD, as we all know, has a complex neurological phenotype because of the striking progressive depletion of sensory and autonomic neurons. the two important aspects that we already talked about and have seen excellent results in this in the previous presentations is about the sensory gait ataxia due to loss of proprioceptive neurons and optic neuropathy characterized by loss of macular ganglion cells, which leads to the vision loss in FD patients. Horatio actually already mentioned it about the vision loss in FD patient. Despite of their complex neurological phenotype, patients suffer from progressive visual dysfunction, which severely affects their quality of their life, which we already know. So one important clinical parameter to measure, to look at the visual loss in these patients is the retinal nerve fiber layer thickness. As we know, there is selective loss of retinal ganglion cells in FD patients, leading to thinning of retinal nerve fiber layer. In this picture, we can see an OCT image where there is reduced retinal nerve fiber layer thickness in FD patients. My interest as a retinal biologist is to develop a therapy in which I could rescue the visual loss in FD patients. So for that, we actually first started studying the visual loss in FD patients using mouse models. There are a few mouse models that were already known, and one of those models, and all these models have recapitulated, by the way, the retinal phenotype observed in patients. One of such model that I'm going to talk about today is a retina-specific conditional knockout model, which is developed by Dr. Lefcourt's group to investigate the role of ELP1, specifically in the retina. So these conditional knockout mice actually exhibit progressive loss of retinal ganglion cells with degeneration beginning as early as 1 month, as we can see here in this graph. And there will be, there is actually 50% of loss of total RGCs by 6 months of age, which makes this model interesting to study the rescue of retinal phenotype. Again, Dr. Lefcourt's group has made an incredible effort and has demonstrated that that the gene therapy works to rescue visual loss. One of the earlier findings is that delivery of intravitreal delivery of AAV2 human ELP1 vector has shown to rescue retinal ganglion cell loss in this retina-specific conditional knockout mouse model. However, what remains unclear is that whether this structural rescue translates into a meaningful functional benefit, and we can actually make the vision better in FD patients. Specifically, whether the visual function can also be restored using this gene therapy approach. So this is the project that we are studying, and to study that if this gene therapy approach can actually rescue visual function in FD mice. We have conducted a comprehensive evaluation of retinal function using AAV2 human ELP1 vector, using various electroretinographic behavioral tests to specifically assess visual function and determine whether structural preservation is accompanied by the functional rescue. In this presentation, I'll share some preliminary results of our gene therapy approach at 3 months post-injection of this human ELP1 AAV2 vector. So the preclinical trial that we have made consisted of 2 different groups, control mice, which express the human ELP1 in the retina, and the experimental mice, which are called here as a PAX6 mice, which do not express ELP1 in the retina. And within those groups, we have control groups and experimental groups. 2 experimental groups are mice injected intravitreally with 5.4 E8 human ELP1 vector at a concentration of 5.4 E8 and 2.7 E9. These are the 2 concentrations that we have used to check if we can rescue visual function. One of the clinical parameters that Dr. Horatio already explained in his presentation is reduction of retinal nerve fiber layer thickness, which is seen in FD patients and also in mouse models of FD. The measurement of retinal nerve fiber layer thickness here is done by optical coherence tomography, which is a non-invasive method to scan the retina and measure its thickness. So we have specifically measured the retinal nerve fiber layer thickness in conditional knockout mice and the control mice to see, first of all, if there is any defect in reduction of retinal nerve fiber layer thickness in this mouse model, and to see if our gene therapy into the eye has worked to improve the retinal ganglion cell thickness. So here in this graph, we can see that there is significant reduction of retinal nerve fiber layer in the FD mice, that is conditional knockout mice. And then we were able to rescue this reduction, where we can see significant improvement in retinal ganglion, retinal nerve fiber layer thickness in mice injected with AAV2 human ELP1 at 1E8 concentration and 1E9 concentration. And next, we wanted to check if the structural preservation of retinal ganglion cells has translated into functional rescue. So we performed pattern electroretinography, which is a non-invasive test that is used to measure electrical activity in the retinal ganglion cells to make sure that the retinal ganglion cells are functional in response to the visual stimulus. So the waveforms are shown here. A positive waveform reflects the initial depolarization of retinal ganglion cells, and the inner retina reflects the action potential generation and RGC output. So reduced P1 and N2 amplitude, as you see, there are three waveforms. Reduced P1 and N2 amplitudes indicate impaired RGC function. So here in this graph, we can see that there is significant reduction in the RGC function in FD mice, conditional knockout FD mice, compared to the control mice. And we were able to rescue we were able to see improvement in retinal ganglion cell function with the mice injected with human ELP1 at 5.4 E8 concentration at 3 months of age, or 3 months post-injection. And one of the other parameters to check the retinal ganglion cell function is a photopic negative response, which is again a slow negative wave going that follows a B wave in a light adaptive full field ERG. So it reflects the activity of retinal ganglion cells again, and also their axon. So here we can see that there is significant reduction in retinal ganglion cell function, which is indicated by photopic negative response, which again is improved by injection of human ELP1 at a concentration of 5.4 E8, which indicates that the gene therapy can rescue retinal ganglion cell function in FD mice. The other thing we've also wanted to check is to see if the electrical response of the primary visual cortex is passed on to the visual stimuli. So for that, we have performed visual evoked potentials, which are again electrophysiological recordings that measure the electrical response of the primary visual cortex to this visual stimuli. In this, we can these VMPs are also used to access the integrity and function of retinocortical pathway from the retina to the optic nerve in the visual cortex. As we can see in this picture, we are measuring with the visual evoked potential. We are actually measuring this the visual pathway. In the graph, we can see that, first of all, there is significant reduction in the visual evoked potentials, which we measured by flash VEP at 3 months of age in FD mice compared to the control mice. And we've also seen that there is improvement in these visual evoked potentials when the mice are injected intravitreally with human ELP1 vector at 5.48 concentration. This indicates that, in fact, we were able to rescue retinal ganglion cell function and also visual function in FD mice treated with human ELP1 vector. We also performed full field ERGs, electroretinographies, to further investigate photoreceptor dysfunction. Photoreceptors are the cells which are on the back of the eye, which are important for receiving the visual stimulus. And there are two different types of photoreceptors: rod photoreceptors and cone photoreceptors. So full field ERG is a method where we measure the electrical responses from major cell types of the retina, which is majorly dominated by photoreceptor responses, both rod and cone responses, based on the dark adaptation and light adaptation. To further investigate if there is any photoreceptor dysfunction in this mouse model, and if there is any, whether we could rescue these defects using a gene therapy approach, we performed full field ERG. So there are two different waveforms that we can see here. A wave, which actually originates from the photoreceptor hyperpolarization, both from rods and cones. But if it is primarily coming from the rods, it is from the dark adapted conditions, and from the cones under the light adapted conditions. And the B wave is actually generated by the bipolar cells under the influence of Mueller glia. So here in this, in the too many graphs in this slide, but I'll try to simplify this. So the upper panel are the control mice, in which we should not expect any differences in the electroretinographic responses, where we can see that there is no difference between the control mice treated with a human ELP1 vector compared with the untreated mice. The lower panel indicates the experimental mice. Those are FD mice treated with two different concentrations of human ELP1 vector. The red line here, the red dotted line, indicates the mice treated with the 5.4 E8 concentration of human ELP1 vector intravitreally. We can see that there is some difference in dark adapted A wave amplitude in mice treated with human ELP1 at 5.4 E8 concentration. But we can see that the larger difference is seen in light adapted B wave when the mice are injected with 5.4 E8 concentration, which indicates that, in fact, there is a difference between FD and control mice, and we were able to rescue the electroretinographic responses in these mice. Finally, in order to see if the mice, if we can improve visual acuity and contrast sensitivity in the mice, we performed an assay called as optomotor response assay, which is again a non-invasive behavioral test used to assess visual acuity and contrast sensitivity in these mice. It actually uses a natural reflex which the mice has when they see the moving vertical stripes. So the mice is put on the pedestal, and then we have monitors around the mice with these moving gratings, which are nothing but the black and white striped lines. So the mice will instinctively turn their heads in the direction of the movement to stabilize their visual field. So this the equipment actually records the head movements of these mice, and then give us the values which are known as degrees per cycle. That means that the white and black white paired cycles that can fit in 1 degree of visual angle. So basically what we can see here is a graph indicating the difference between the control mice, that is PAX6-3 negative mice, and the PAX6-3 positive mice, which indicates that there is significant reduction in visual acuity in the PAX6-3 positive mice, which are FD mice. And then we can also see that there is significant improvement in visual acuity in mice injected with both 5.4 E8 concentration of ELP1 vector and 2.7 E9 concentration of ELP1 vector. Similarly, we can also see that there is significant improvement in contrast sensitivity. First of all, there is a significant difference in contrast sensitivity. FD mice showed reduced contrast sensitivity, and then we were able to improve that reduction in contrast sensitivity by injection of human ELP1 vector at human ELP1 vector at 5.48 concentration. So we can see this contrast sensitivity improvement at both two different cycles per degree amplitudes, and we can see that the significant improvement is with 5.4 E8 concentration of human ELP1. To conclude my presentation, our results indicate that AAV2 human ELP1 administration of AAV2 human ELP1 intravitreally in conditional knockout mice has led to improvement of visual function in mouse model of familial dystonia. And we still are in the process of demonstrating the safety and efficacy of this AAV-mediated gene supplementation approach. And we wanted to test the safety of this vector in non-human primates in order to move forward with human administration. And in parallel, we are also doing transcriptomic profiling of retinas treated with human ELP1 to detect the molecular pathways which are dysregulated in FD retina, and also to see if our gene therapy approach can rescue those dysregulated pathways to drive selective retinal ganglion cell regeneration or renewal in these mice. Parallel, we are also working with other groups to generate an iPSC-derived RGC model to actually further investigate if we can test this human gene therapy approach in a humanized model of humanized RGC model and see if we can rescue these defects that we have seen in mouse models. With that, I would like to thank my mentors, Sue Slogan-Hapt, Elizabeth Amorini, Daddy, and KK from MGH. And all this work is done by visiting a scientist from Taiwan, Hui-Chan Chang, from my lab at Grousbeck Gene Therapy Center. I would also like to thank Ocular Genomic Institute and my funding sources, National Eye Institute, and more importantly, Familial Dystonia Foundation for the Early Career Investigator Award, which allowed me to perform all this work. Thank you very much.
Hi, everyone. I'm sorry I can't be with you today live on Zoom, but I'm happy to send this recording to give you a brief update on our work to develop a drug to treat familial dysautonomia. I'm Sue Slogan-Hapt, for those of you who don't know me. I am at the Mass General Hospital in Boston. I'm also a professor of neurology at Harvard Medical School, and my lab is in the Center for Genomic Medicine at MGH. So we've talked for many, many years about correcting ELP1 splicing using a drug. ELP1 is the gene that is defective in FD. And the goal of our work, as you know, is to create a drug that can help us include exon 20. So just as a reminder, in FD, exon 19 should join to exon 20, should join to exon 21. What happens when the FD mutation, which is right here, is present, exon 20 is skipped, and this leads to no ELP1 protein being produced. What we're trying to do is come up with a drug that will correct this such that it goes this way, includes exon 20, and creates functional ELP1 protein. And we want to increase the level of functional ELP1 protein. So that's the goal of the work that we've been doing. So what have we been doing lately? We have a drug called PTC680. And we were awarded an NIH Blueprint Neurotherapeutics grant that I told you about last year in 2023. This work actually began with kinetin way back in 2004, 2005 when we found kinetin. And we've been working since then to create a better drug for FD patients. So we began work with the Blueprint project at the National Institutes of Health in 2012 originally. Worked with PTC Therapeutics for several years, and now we're back working with the NIH Blueprint Neurotherapeutics Network. So this is just a list of the individuals. This is a true team effort coming together to treat FD. My team at MGH, along with those at the FD Center, Dr. Kaufman and Dr. Gonzalez Duarte, as well as many consultants and people from the NIH who are helping us to bring this drug to FD patients. So last year, I told you about the first year of the grant. This year, I'm happy to tell you we've had many accomplishments. The first is we've completed the studies on the pharmacology in mice. We've been able to show that this drug, PTC680, also called BPN 36964, rescues disease phenotypes in mice. So this drug corrects the phenotypes that we see in our FD mice. We've completed studies. DRF stands for dose range finding studies in dogs and in non-human primates. We've completed those studies. We certainly have collaborations established with clinical specialists at the FD Center, so that milestone is complete. We know how to synthesize this drug, and that's complete, and we've done pre-formulation screening. So these are all steps in the drug development process. And the thing left to do for this year was to prepare material for our IND enabling studies. And I'll talk a little bit about that on the next slide. The important takeaway here is that all of the data that we've generated strongly support the continued development of this drug as a treatment for FD. So next year, what are we up to? We just got our grant renewed. That is great news that the NIH renewed our grant. And the goal for this year is to do two things: synthesize the drug so we can do toxicology studies. So we need a lot of the drug. And then we need to actually do the toxicology studies, which will give us crucial information about the safety and toxicity of the drug before it goes to people. Okay, so what is happening right now? Nothing. And the reason nothing is happening is because of what is going on with the current administration. More than 800 existing NIH research grants have been terminated. Grant reviews have been held up and research funds have been frozen. So I told you that our grant was renewed. Good news. However, in order to do those two things I just told you about, NIH has to contract with a company in order to produce the drug and then in order to do the toxicology studies. Those are contracts. Contracting at NIH is halted. So our project cannot move forward in any way if contracts can't be awarded. So what can you do to help us? I hope you've already been doing this, but write and call Congress. Tell your friends to do it too. Talk to anyone who will listen. If we can't get funds through NIH that support biomedical research and we can't unclog the contracting, our project will not move forward. So I'm sorry to be the bearer of both good news in terms of the progress we've made, but also bad news in terms of the fact that while some grants are getting renewed, like ours, which is good, without contracts, this project that I just described to you can't move forward. So please help. Do what you can. We need to be screaming louder about this, and we need Congress to be screaming louder about this. Lives are at stake. Again, I'm sorry I couldn't be with you live to answer questions. Anil is here with you today. Elizabetta is here with you today. And this is the team at Mass General who has worked on FD for a very long time. And we are determined to keep going. We are determined in order to get this done. We just need a little help from Congress, from the administration, and from NIH to get the contracts going. Thank you. Enjoy the rest of the day.
Good evening, everyone. First of all, I must say how impressed and incredibly encouraged I am with the mLOREM data, the ASO data. To date, a veteran of the industry, I know how much work it takes both in the lab and in the clinic to get to this point. Moved to tears, just heartfelt congratulations. As the father of a 31-year-old FD young man, I guess the burning question is whether these fantastic results will translate to our older patient population. And I look forward to answering that question. My son suffers from severe gait and vision loss issues, and can't wait to see what the future holds. Next slide, please. So just as a reminder, we kind of introduced Tikkun at our last FD Day. Tikkun is a public benefit corporation that we set up as a wholly owned subsidiary of the foundation, the FD Foundation. Its mission is very clear, sort of the business side of things, to aggressively drive drug development for FD, which currently has no available drug treatments, and as its unwavering focus, working with transparency with all of our stakeholders to ensure unfettered access to whatever approved drugs become available for FD patients across the world. You heard a lot about the ASO progress. Tikkun's focus over the last year or so has been our gene therapy vector that Anil spoke about and the small molecule that Sue just spoke about. I want to thank the team that I'm working with, and in particular, Frances Lefcourt, who's been my partner in all of this, could not have made anywhere near the progress without her incredible contribution. Next slide. So the message, and I kind of am echoing Sue Slagenhoff's message here, is that we're at a critical juncture right now. We have never had more compelling data for both the gene therapy vector and the small molecule drug candidates. It's just screaming for more investment. It's screaming for more attention. But at the same time, our geopolitical situation right now, the NIH funding, Sue talked about the Blueprint grant. Recently, we filed an SBIR grant for the gene therapy vector, which is a small business innovation research grant, a grant that's only available to companies like Tikkun, not nonprofits. This funding is at severe risk due to the current geopolitical situation. So we're in a tough spot. We have the greatest data we've ever had and the biggest threat to our ongoing funding that we've ever had. In terms of our progress over the last year, since the last time I spoke to you, we have filed our ELP1 gene therapy US patent application, done. We have executed a gene therapy vector license agreement with Montana State University. It's been completed. About a month ago, we submitted our SBIR phase 1 grant application. That's for the gene therapy vector that was submitted. And just to give you a sense of scale, that phase 1 grant's worth about $300,000, something like that. That's enough to produce the vector for toxicology. And that's when we have to get a new infusion of funds. So it's all about money at this point to keep these programs going. The MGH Mass General Tikkun sublicense agreement is in progress. We're working hard on that. That's for the small molecule. And I've developed, with some big contributions from our SAB, a pitch deck to be used for both investor and philanthropic community presentations. That's been completed. A couple other quick updates. We've expanded the scientific advisory board for Tikkun to include my good friend, Dr. Todd Wolf, who's the executive director, Technology Ventures at Beth Israel Deaconess Med Center. And a shout out to Todd, whose birthday is today. And also, most importantly, and this is very timely, we have to get in front of the NIH in what's called an Interact meeting. This Interact meeting is really important. It's informal, and it allows us to have a conversation before we do any more submittals. Are we using the best, are we making the best choices for efficiency's sake, financially? Are we choosing the right animal model for our toxicology? Those kind of questions. I'm very optimistic they will grant us that meeting, and we hope to have that this summer. So, priorities for the remainder of 2025, very clear for us. Protect our IP, continue to get these agreements in place, secure required funds in any way possible. And of course, as you can tell from all this incredible inertia that we have, all this momentum that we have right now, to maintain that momentum with the greatest sense of urgency. So that's a quick update. And I'm now going to turn it over to Dr. Patricio Millar, who's going to facilitate our Q&A. Thank you.
We're going to be moving forward with the Q&A session. We've been collecting the questions that you've been submitting to the Q&A box throughout these sessions, as well as the questions that you had during the registration. We've been seeing and hearing amazing things about the genetic and gene therapies and all of the results with the ASO. So logically, there's a lot of questions about that. There's questions going from the spectrum from the research, basic science, and clinical care teams. So we're just going to start with the first question, which is something that a lot of people are concerned about, which is at this point, do we have enough information to know if there will be any limitations to which age spectrum will the ASO will be restricted to, or if it will be limited by how affected people with FD are, by the severity of their different symptoms or nerve dysfunction?
Patricio, you want me to try to tackle that?
Go ahead.
So, number one, you have to remember that there's a combination here of, I'm going to try to put it in the best possible words, between science and regulatory issues that the Food and Drug Administration has. So in order to make our pitch initially, we emphasize the need for treating very early and only young patients. Remember that our goal was to overcome the limitation that the FDA had for this special path that Sarah Glass and I think it's only Sarah mentioned that path, meaning this easy or accelerated path of the FDA was based on diseases that affected less than 10 people. So we, in order to make our pitch, after we convinced Adrian to produce the ASO, and he made the ASO, so we had the bomb that would do the thing, and NLOREM chose us also, then we had to make sure that the FDA agreed. So we emphasized the fact that people had to be very young because of those lines that I showed you. Now, all these, whoever asked this question, all these is all predicted, and we may be wrong. There may be, look, we were not expecting regrowth of peripheral nerves. Really, we were not. Several of the things that we saw, we were not expecting. Now, are these reproducible? It's only one patient. But before going to that and putting, some reality, my point is that we want to treat everybody. We would like to treat everybody, but we have to go one by one. So remember, before finishing 1 year, we already have a second patient and we are trying to treat a third. So are there limitations? Well, there were limitations that we express. We want to apply now patient by patient with older patients and see what happens. And we believe NLOREM will also be supportive. Remember, Adrian did the drug. NLOREM put the salt, that thing of the 5 fingers. So he made the drug. NLOREM, they put the salt. The center got the drug and we gave it to patients, right? We have to keep repeating that. We want to give it to as many patients as we can. And remember, our goal is not FDA, quote unquote, approval for the general public, because at some level, we don't care about the general public. We want to treat as many patients as we can, as fast as we can. And of course, we want the other 3 drugs to continue on development, particularly the oral one that we are working with Sue and Elisabetta. And let me emphasize that all these techniques are potentially complementary. They work in different ways, and they all correct the splicing defect. So one could envision a situation where a patient is taking a compound by mouth, right? This kinetin derivative. He's also getting an ASO and perhaps even getting gene therapy in the eye. And if Elisabetta gets her act together, CRISPR will be ready, and then we will not need any of these. There will be one and done. But Elisabetta, why are you not working on it today? So if she keeps working on it, perhaps we really get something that requires just one treatment. Look, genetic era has begun, and we are on that path. Let's hope for the best, and let's be optimistic. That's
Horacio, but who's going to pay for that? The cost of each treatment is tremendous. So how this can reach all the patients? Let's say that it's effective, and you can manage to treat 300 patients. From where you get the money? So who is going to pay for that? I mean, this is the reality. could work fantastic, and it looks fantastic. So how we get
Well,
to patients?
I can read. I cannot hear you. I can read the. Okay, two things. You say who's gonna pay for this? Certainly not Israel. So let me make this clear. NLOREM is committed to provide lifetime supply for each patient. That's number one. So the only thing it's still very expensive to treat each patient. The treatment for the injections in the US is around $60K per patient for a 2-year trial. And that is because the cost of care and admissions in the US is very high.
Yeah.
So the foundation, the FDA
This is cheaper
Foundation
here
is
in
paying
Israel,
for
if you
that.
think about that.
Now in Israel, clinical care, as you know, is free. So NLOREM provides the drug. If Israel gets her act together, which we would really hope, Miguel, we've been waiting for 15 years and we have not been able to do that. But if you guys get your act together, we spoke with Tel HaShomer, and maybe we should talk with Hadassah too and see if somebody takes the gauntlet, because NLOREM is ready to provide the drug. You just have
Fantastic.
to provide the medical care and the idea. But again, Miguel, it's up to you guys. It's up to you. And let me throw publicly this gauntlet that we still
It's
haven't
great.
been able
I'm
to
only
share
a
data
parent
with
in
you
this
guys.
case, but okay, it's something that we need to put pressure on it, but we need some data. I mean, understanding how much this costs and what is the burden on the HMO system. So probably HMO
Yeah,
could pay.
Miguel, I cannot hear anything. I don't know if the rest of the people can.
You can hear me? Yeah,
Okay.
everybody hears me.
Yeah.
So maybe it's our NYU connection. Okay.
So you read my lips. We can speak in Spanish if you. But it sounds great. I know. But the thing is how the cost will be managed. And how do you know what the repeated sequence of treatments for how this can
Miguel,
go?
Israel has more companies in the New York Stock Exchange than any country in the world. You have 100 patients. It's about time that you get your act together and collect some money to pay for this. Israel is not an underdeveloped country anymore. So let me be
We
very.
are not.
I'm just wanted to cede the floor to Laurie Mignon from NLOREM.
I just wanted to, this is a very interesting discussion. Obviously, finances are always needed in this. I just wanted to bring it back to the question of who could be treated or if everybody can be treated. I think Horacio made a good point of, we obviously had a strategy and we needed to go in with somebody where we could still potentially see reversal of symptom or, reversal of disease and definitely improvement of disease and so forth. And so that's why we went with the patients we did. I would say that upfront, I personally don't think that there's a patient too late to be treated because we do never know what we would see, right? And so I think that is just really something we should all keep in mind. However, also, and this is really just for the ASO treatment, and so we'll do this until, Adam and Elisabetta get the other treatments going that may not require LPs, but for now also, we need to be able to do an LP at the L4, L5 level, right? And so if patients have, again, issues in the lower back, maybe, scoliosis, fusions or things like that, that could be something that prevents a treatment. And so if any patient needs to get, spinal fusion, maybe keep a window open, make sure the surgeons know that and things like that. So I think that's what I wanted to say, because I think from a perspective of, is anybody too far progressed? I don't think any of us can tell. We don't know until we try it. And so, but to Horacio's point, we had to go in to the FDA with a patient where we could show safety, again, for far and foremost, but then also potential benefit. And so if you went with somebody maybe too progressed, that, that bar would have been higher. So I just wanted to bring that point to the table.
Yeah, Dr. Craner.
Let me unmute. Yeah, it seems to me that there's a case to be made for treating an older patient, one, just as a start, sooner rather than later. And so we'll have more information. And it may be that path is easier in Europe or in Israel at the moment than in the US. It's just something that needs to be explored, I think.
And I encourage, I don't know which buttons to touch, but we'll be happy to move the needle forward if it is needed. So I'm here, and definitely something impressive. I've never seen something like that before, and needs to be explored. I would be happy to
Okay,
address
these have
the
been very,
possibility
very
here.
comprehensive answers to a question that was branched off into basically a little bit of all the questions that we have. But going back to one of the things that we were mentioning earlier, and I want to bring the spotlight to Dr. Gonzalez Duarte, who's actually doing this, is if we have a patient with a spinal fusion, could that be a limitation to administering the ASO, or could be there other methods or ways to bypass this?
I think that, thank you, Patricio. Lori Mignon made a great she already answered the question. There might be some other things, not only the spine fusion, but we have to treat every patient and see which risks they will go to undergo this amazing but very, very complicated treatment.
And I would add, if somebody has a spinal fusion, we have for other programs had where the patients could talk, or neurosurgery could come in and maybe do a window so that, I mean, depending where the fusion is, and, so that there would be flow and, and I mean, you could enter and all of that. So I think there's ways of doing it, but obviously easier to talk about that before any surgery is done than after. But even after, I think it's not a complete no-go.
Okay, that's very reassuring to hear about that. So connected to that a little bit with something that Dr. Gilbert was also bringing about is like right now we're administering the ASO with a lumbar puncture, but could there be, with the knowledge that we have now and that we are acquiring, would there be a pathway to administer the ASO through other ways of administration, other routes of administration? There's not a lumbar puncture.
I can take the first one, and then if anybody else, Adam or anybody else wants to jump in. So currently, again, it's under this guidance of the FDA for individualized ASO development for severely debilitating or life-threatening diseases. It really covers antisense oligonucleotides of a specific chemistry using a specific route, right? So it's TUMO ASOs, and the routes are really the routes that through commercial entities have been shown to be safe. And so it's intravitreal, intrathecal, and subcutaneous. But subcutaneous doesn't work if you need to get to the brain, because ASOs don't cross the blood-brain barrier. So if you need to go to the brain, intrathecal right now is really the way. I know that for obviously Spinraza, who has been on the market for a while, people are considering, and even Biogen are doing studies of, doing Ommaya reservoirs. So you would have, a port, and then you would be able to fill it up like that. But right now, the pharmacokinetics have been studied extremely well if you do an IT, a bolus injection, through the lumbar puncture route, and the pharmacokinetics are known. And so that's why that's really the route to go right now, to go into the brain. But I don't want to say that, there wouldn't be something else in the future, but because this is already investigational, the FDA gave us a very set path to get to humans. We can't, stray away and go into a completely investigational way of giving these drugs, because we don't know the pharmacokinetics that well of other means.
May I ask something? What will determine a second dosage for the same patient? The decline of the improvement, or what will be the indications to do a second shot?
So for antisense oligos, it is repeated injections, just like Spinraza. So it's not a one and done for ASOs. It's really, you're giving it all the time. For splicing ASOs, we know that they have a slightly longer half-life than another, knockdown ASO is another mechanism. And so we know that it's about every, 4 months is what we see that works. And so it's pretty, you load it a little bit at the beginning, when you do it after 2 months, and then after 2 months, and after that, it's every 4 months.
So these patients that were shown, how many shots they got? That was not clear.
I think the first patient got 4.
You're muted. Okay, sorry.
Yeah, it's Miguel, I show the protocol and you can read it. It's an injection every 4 months.
Okay, great. Thank you.
Okay, so connecting those questions a little bit with some things that Dr. Kaufman was mentioning and Dr. Morini showed in her talk, where mouse models were being quote unquote treated with both gene editing and the PTC compound. Both this has been brought up in the talks, and people have been asking if taking part of one trial with an ASO or with a PTC compound, or in the future with the CRISPR technology, will preclude patients from receiving another therapy at the same time. Could they participate in both clinical trials at the same time? Oh, I think Dr. Kaufman, you're muted.
I guess if we have CRISPR or any of the other methods available, we'll consider it then. Usually you cannot have two experimental therapies at the same time, but so all these are regulatory issues. You know, from a science point of view, yes, they could be combined. Of course, as I was trying to mention before, if Elisabetta, instead of going on vacation so frequently, would be working on her CRISPR, we would have CRISPR already, and it would be one treatment. So look, aside from the joke, if one day CRISPR works, you know, that you do it once and you correct the defect. It has been, I think it's only one treatment efficacious, one disease, right? Published recent, one disease. So let's hope. This is even more science fiction, but it may happen.
That's great, but the time is ticking, but for the older patients. Okay, so there needs to be done kind of in the clinics to understand what will work best for those that
Miguel,
are aging.
there is a treatment available now that is the ASO, is per patient. We are trying to get Israel. I mean, I know I'm being difficult. It's the fourth time.
I'm not a representative of the Israel government.
Everybody.
I learned this for the first time.
Okay, now
tomorrow morning I will try to get people.
Okay,
I guess Bat and Alex need to be, you know, sharing this information.
Oh, Miguel, they know. Everybody knows. They just don't answer. So let's make this very clear. Again, I'm not a politician. They don't answer.
It's clear that you are not a politician.
Okay, now you heard it. You heard it. The treatment is, we've been talking, and Lorem will help. You just need to get your act together, and let's hope we can treat the patient.
I think it's, well, I don't know if it's doable, but it should be. You know, we need to move forward with this. Yeah.
Just to clarify, I mean, as part of a study, you don't want to use two experimental drugs unless that's a study design, because then you are not going to be able to tell which is working, or, you know, so that's not the way to start, I think, you know.
You don't have enough patients to do the placebo.
So moving on with so we have time to answer the questions that the families and patients are asking. Another question related to research and drug development is if AI, artificial intelligence, or new technologies can help in discovering either new medications or help reusing previously known or discovered medications already. So this question can be, I think, Dr. Craner, Madam Sachs, Elisabetta, if you had experience with this kind of research approach.
And what was the question? If we can repurpose old medications?
If artificial intelligence or other technologies can help discover new medications to treat familial dysautonomia, or repurpose, reuse already discovered or available medications for clinical trials?
Yeah, in theory, yes. There's no reason why that could not be helpful. Remember, and Elisabetta can tell you, although she's very young, that kinetin, the drug we are working on, came to fruition because
an FDA
method like that, right? This was they tried like 40,000 different compounds on a chip, seeing which one would alter the splicing.
That
and
was
that's how
4,000.
kinetin appear, right?
That is correct. I'm not an AI expert, so but definitely a repurposing drug is it would be is always good because you can go like if they're already FDA approved.
But for a repurposing drug, you need to find out which outcome to
yeah,
fix.
and in our
it's not
in our
only one.
case, yeah, ELP1 splicing is quite easy.
It's the best you can. Yeah, it's the utmost. Yeah.
One of the questions that we had is related to the different talks in what we've seen with the ASO treatment, that we've seen improvement in the retinal cells and in the regrowth of the nerves in the skin, leading to improvements in balance and perception. If this can be used to know that if nerves will be growing in other parts of the body and help improve other symptoms, like for example, swallowing.
We are looking at everything. You know, I want to emphasize that we did modeling for many years, trying to see what a drug could do. But these were all suppositions and hypotheses. Now we are actually treating a patient, that will be the second, and we'll see, right? We will be, Coach Miguel, go ahead.
No. I have a question for you.
Can I answer that? Remember, I showed you two different clinical results, two different results. One was the biological things that we are seeing, including that renervation of the skin, and the other is the clinical significance of this. So I think that we are very early yet to see what is the repercussion of what we are seeing. Having renervation of the skin, of course, it's very, very exciting, and it makes us look forward to other results. But we need time and we need patience.
And what about crisis? Do you manage to improve crisis?
We don't have a very good measurement for crisis. And one of the things is that people will say that they are still ongoing, the parents say, but they need a little less of the medication. I mean, the medication is more efficacious once that is given. We need to have a lot more time, a lot more patience again, and a lot of more registration so we can see that this is really meaningful. We're treating one patient and we're all very excited, so we are very subjective to some of the
So this patient, let's say, if it was treated previously with carbidopa, he stopped the carbidopa treatment?
Family?
There is no more information that I can give you at this point about the medications. We'll have to do a lot more of analysis, Dr. Well.
Okay. And I would just add in general, and you know, Adrian was also mentioning that before in terms of the treatments, but in general, we keep people on whatever drugs they were on, you know, for a long time before you start an investigational one, because otherwise you're changing two factors now, and then you wouldn't see what the new drug is doing. So we can't remove, especially for under this guidance, I say we would not remove something that a patient is on. It's keeping them safe. I mean, that's standard of care for that patient.
That's a good point.
And then an ASO would be added on top of that. I would also just like to give a shout out to the entire FD community and Dr. Horacio and Alejandra for all they've done also in collecting that natural history study and all that data on patients beforehand, because it is really because of that changes can be seen now, and that they can do the modeling and they can see if anything is improved. So I, you know, really feel that this is very important, that all the information that was collected for many, many, many years is also what helps in the development of, you know, such thing. And I'm not sure that other foundations would be listening to this, but if they are, this is really what is needed to be able to have that longitudinal data, because it makes it much easier at this point now, because you have the slopes that he showed, and now you can see that we're changing. So anyways, just wanted to take a second to say congrats on that work.
And just to highlight what Dr. Gonzalez was saying is that sometimes besides all of these measurements that we're doing during all of these visits, needing less of a medication or using a medication less frequently can also be an indicator of improvement in certain areas. And at the same time, that sometimes, I mean, I think that everybody's just incredibly surprised of how rapidly we've seen all of these changes with this therapy, but that doesn't mean that we won't continue to see more changes in different domains over time.
Remember also, we are very excited and incredibly happy. I hesitate a little bit, but I also want to say that this is one patient, one occasion. We have to reproduce it. We have to make certain that this is not biological variability. Remember, we are used to doing clinical trials. And in clinical trials, you need statistics and controls. Here, we are using the very peculiar statistics, meaning we are comparing one patient versus the history of others. So there are potential pitfalls and meaning we are flying with excitement. I just want to tell you that it's important to keep a little skepticism. And we oscillate every day between being elated, flying, and then saying, oh, shoot, what if this is not persistent or doesn't happen to everybody, right? I just want to emphasize that the big emotional roller coaster that we have, depending the day. Some days we say this is real. Some days we say, well, it may be a biological variability. We need time. And rest assured, guys, that we are following these patients like hawks. We are measuring everything, asking all sorts of things, and we will see. We will definitely see what happens. What we need is more patients treated. Now we have a drug, it's possible. Places where there are many patients, in the same way that Sue and Francis and Elisabetta told us to call our congressman. You call your doctors in Hadassah and in Tel HaShomer, and you tell them to get their act together.
Brilliant.
Okay, so that's all the time that we have for now. Thank you, everybody, again for joining in, for all the work and collaboration that you've done. I think that this has been an amazing year for FD.
Bravo.
And I'm going to hand off the stage now to the Executive Director of the FD Foundation, Lainey Etkin.
Hi, everybody. The Q&A panel is such an interesting and engaging component of the FD Day program. Thank you, Dr. Millar, for moderating this segment, and thanks to our panelists for participating. If the group did not have an opportunity to address your specific question, please submit it to info@famdis.org, and we will do our best to get an answer for you after FD Day. So far today, we've heard from our amazing clinical care team at NYU Langone, and we've heard the latest updates on FD research. In the brief segment to follow, we will be highlighting several programs offered by the Foundation that aim to enhance the mental and emotional well-being of people living with FD and their loved ones. First, social worker Matt Hertzberg will tell us about the 4 different support groups he is facilitating for caregivers and family members, all of which are open to new participants. Next, Michelle Schwab will talk about the virtual hangouts and monthly game nights that she facilitates. Please note that Michelle will be hosting an after-party game triathlon for people with FD following the conclusion of today's FD Day program. We will post a link at the end of the program so you'll know where to meet Michelle. At last, we will hear from Lily Armstrong, who collaborates with the NYU Dysautonomia Center to provide one-on-one virtual support through the Stevie Schwartzberg Mental Health Counseling Program. Lily's taking some time off this summer to deal with a personal family issue, so we've repurposed a video that she made for another event to share with you today.
Thank you and hello. For those of you that don't know me, I'm Matthew Hertzberg and I'm a social worker in New York and New Jersey. I was first introduced to FD while interning at the Dysautonomia Center, working with world-class doctors and researchers in the field, and meeting several extraordinary families living with FD. In 2023, I began facilitating a virtual caregiver support group for parents. These casual meetings offer a space for FD parents to share their knowledge and experience with others, their ups and downs. It is my hope that parents leave feeling less isolated and more confident in their work caring for someone with complex medical conditions. Since then, I've been asked to develop and host 3 more virtual support groups. In 2024, the first FD Parents Grief and Bereavement Group. Earlier this year, the FD Siblings Support Group, and the recently launched Grief and Bereavement Support Group for Siblings. With their permission, I'd like to share a short observation from the FD Parents Grief and Bereavement Group. We talk about grief and we talk about love. Here with each other, we still get to be FD parents. Our conversations feel like looking in the mirror. Our conversations feel like looking in the mirror. I believe this sentiment rings true for all of the groups. Nowhere else can you hold space with others that understand what you and your families experience daily. Nowhere else can you share that common bond with your FD peers, spanning borders and generations. I'm proud that the Foundation sees the importance in addressing mental health needs, not only for patients, but the family as a whole. Sharing in the common bond, having hard talks, celebrating the successes, and being there for each other when necessary. It is my privilege to be a part of that conversation. These groups are ongoing and open to all. If you or someone you know may benefit from any of these groups, please reach out to me directly or through the Foundation. Thank you again, and I hope you all have an excellent FD Day.
For those of you who don't know me, my name is Michelle Schwab. I'm the group facilitator for the FD Hangouts program. The FD Hangouts are a virtual space where folks in the FD community can connect with their peers in similar age groups. We currently have 4 different Hangout groups, as well as a monthly game night for all age groups, where we play games like Jeopardy, Name That Tune, and Family Feud, to name a few. Our current Hangouts consist of our Orange group for folks in the 40 to 60 range, which meets weekly on Thursdays at 7:30 p.m. Eastern. The Green group for folks in the 30s range meets every other Wednesday at 8 p.m. Eastern. The Yellow group for folks in the 20s range meets every other Wednesday at 7 p.m. Eastern. And the Blue group for our teens meets on the alternate biweekly Wednesdays at 7 p.m. Eastern. For those of you who are involved in our groups, thank you. Your involvement truly makes the FD Hangouts a really special place for community. For those of you who are interested in becoming involved, please feel free to reach out to the Foundation, or you can contact me directly for more information. I'm looking forward to hopefully seeing some new faces at our next Hangout.
Hello, everyone. My name is Lily Armstrong, and I'm the mental health counselor with the Familial Dysautonomia Center. I am so grateful that you have included me in this event today, and we are here today to build a legacy. And I see that as one of the huge strengths of this program, is to offer a meaningful connection as my clients struggle with some of the complexities of having a lifelong chronic illness. So I'll share one quick story with you. I have a client who's in his mid-20s, winsome, creative guy who has recently lost the mobility in his legs and is now utilizing a wheelchair. So he has all the resources physically to help him make this adjustment. But what I care about, obviously, is the heart and the spirit. And in the last few weeks and months that we've been working and talking together, he has started to see and shift some of his perspective, that what previously felt like a problem that was never going to go away, never going to shift, is now becoming something that he has optimism and perspective and hope for his future. And I see this as the biggest strength of what we provide with these mental health services, these teletherapy services, is some of the complexities that people go through with chronic illness can now be some of the opportunities that they see as hope for their future. And a partnership has foundations in compassion, care, encouragement, and support. We're living in a really anxious time, and there's a lot of uncertainty. And I think having these mental health services helps encourage the spirit and empower the person to start living a more fulfilled and meaningful life, regardless of some of the hardships and circumstances that come their way. So thank you so much for this partnership. It means so much to us. It means so much to me. So thank you, Schwartzberg family, from the bottom of my heart. And thank you to all of you.
All three of these very special programs offered by the FD Foundation are made possible through your philanthropic support. Additionally, the Schwartzberg family continues to raise funds to sustain the mental health counseling program in memory of their son, Stevie. This year, Stevie's sister, Daryl, is spearheading an evening of comedy, Laugh for FD, in Toronto, Canada, on October 27th. Why not join us in Toronto to support this event? Check the foundation website later this summer for details. Here's a quick preview.
And lights. Hi, I'm Chelsea.
And I'm Tony.
And we are members of Second City Toronto's touring company.
Here in the legendary Theater 73. We are looking forward to Laugh for FD comedy on October 27th.
It's going to be a hilarious show and it's for a great cause, so we will see you there.
What's that hat for?
They need to know it's a comedy show, so I brought something funny.
Oh.
Here, you hold that. That's funny. See you on the 27th.
Happy Halloween! No, it's not
No, it's
Halloween
not.
yet. Oh.
Hi, everyone. Today's clinical and research talks all point to a new frontier in the development of therapies for FD. These possibilities bring new hope for people living with FD. But what this community has always shown us is that people with FD will continue to defy the odds no matter what. This year, we want to highlight two amazing individuals who are pushing boundaries every day and who have persevered to accomplish incredible things. Hanuk has a bright, inviting smile and a determined spirit. He faces each new challenge with excitement and bravery. He knows that the key is going slow and taking each day one at a time.
Hello, my name is Sophie. I live in Edinburgh, outside of London in England.
And how old are you?
15 years old, nearly 16. And I have FD. I don't let it stop me from feeling I want to do.
Hanuk credits his amazing family and friends for their unwavering support of everything he sets out to do.
What mainly helps me, and it might help you even, like having people support you and setting you on of what you want to do, and that is your most amazing family and your friends that stay you on. That helps anyone, and that's what everyone wants to do.
He is excited for what lies ahead and will continue to push boundaries to achieve his goals. His advice to other people with FD is to always face your fears.
A long time ago, because of my FD, I went underwater and I went on my nose and I couldn't breathe. But for a year after that, I faced my fear, went underwater again, and now I love it. So what I'm trying to say is, no matter what disability you have, or if you do have FD like me, just face your fear and do whatever you want to do.
Franny is a young woman with an incredible strength and drive towards achieving her goals.
Hi, I'm Fanny. I'm 30 years old. I live in Charlotte, North Carolina. And this is Catherine, where I work. Welcome.
She has a heartwarming smile and maintains a positive attitude no matter what life brings her way. She enjoys traveling, knitting, and trips to the theater.
I love working at the KCC and being part of my community.
She also works in a cafe as a barista, making delicious coffee drinks.
Latte.
Franny takes pride in her work, and this has helped her to forge an independent spirit and motivates her to keep reaching for the stars.
We love you, Franny.
We love you, Franny. Love you, Franny. We love working with Franny at the JCC. I love seeing her smile every time we walk in.
She recently enjoyed a huge 30th birthday celebration that included traveling to Paris and New York City. She treasures time spent with family and friends who support her. Franny is courageous, ambitious, and excited for everything that's coming towards her.
For those who have FD like myself, I know some days are going to be hard, but the FD Center is helping us to have better days ahead of us. And be kind.
Congratulations to Hanuk and Franny, this year's distinguished honorees. You are an inspiration to all of us, and thank you so much.
Once again, we have arrived at the best part of FD Day, the art competition, this year called The Artists and the World Through Their Eyes. My name is Dana Stoddard, and this is my second year that I've been honored to help judge the competition alongside 3 other exceptional judges. 2 of them, Sherry Cammey and Sam Goodsell, both my teachers and mentors whose work has been exhibited around the world, are returning from last year. We are also thrilled to welcome a new judge, Amy Glasswand, a lifelong artist and my classmate for many years. Together we formed the perfect team for a very challenging mission, each bringing unique tastes and perspectives. This year's art is out of this world. As far as we are concerned, everyone is a winner. However, given the daunting task of determining first, second, and third places, we did our best after much deliberation, as all entries were imaginative, adventurous, courageous, and just plain simply wonderful. As a songwriter Usher says, as long as you're bringing passion with you, continue being willing to stretch. It is clear that all the artists have done just that through their imagination, their perseverance, and courage in their work. And now we'd like to introduce you to our artists. Morgan Oskanowski. Superheroes is the title of this artwork. Using magic markers and colored pencils, we are looking at Captain Marvel, Green Lantern, Robin Teen Titan, Supergirl, and Superman. We found this artwork to be very well done. Morgan's role models inspire hope and encourage us to realize we are all superheroes in our own way and with the right attitude and optimism. Magnificent job, Morgan. We have Andrew Sigmund, his work entitled Garbage Pail Kids. Using AI as his creative partner, the judges were unbelievably impressed by how Andrew used this to brainstorm ideas, refine the look, and explore layout options. He says AI makes it easier for someone like me who doesn't have all the tools others have to bring an idea to life. The judges loved the self-portrait and the fun imagery that conveys both chaos and connection. Andrew uses his art to raise awareness of invisible disabilities while celebrating creativity and the ability to laugh at life's absurdities. Our next artist, Diana Esperanza, entitled her piece, My Happy Place. Using photography, Diana shows how she has made her room a happy place filled with her toys, TV, and iPad, along with all those machines. Although she doesn't love the machines, she acknowledges how much they help her feel better. Her work teaches us the power of creating a joyful environment. And next we have Franny Cohen. Her work entitled Paris at Night, again using photography. Franny shares her dream come true trip to Paris with a striking photograph of the Eiffel Tower. The timing of this shot was beyond perfect. She allows viewers to experience the magic of Paris through her lens. Beautiful job, Franny. And then we have Gabrielle Jassy. She submitted a self-portrait, again, using photography. Gabrielle presents a bold celebration of resilience, inner strength, and transformation through 4 powerful self-portraits. She honors her growth with a blend of quiet reflection and fearless self-expression. Her message is clear. Transformation is deeply personal, beautiful, and a very creative composition. And next we have Justin Sachs. 2 pieces he submitted to us, one called Moving Forward and the other called A Bright Future, using acrylic paint. Justin's painting of a train crossing a fragile bridge at sunrise symbolizes strength, resilience, and hope. And I quote from him, "Even a strong, heavy train can cross the most fragile bridge." His second piece, Bright Future, represents life, renewal, and the beauty of spring. Exceptionally done, with vibrant color and thoughtful composition. The judges loved his work. And next we have Camila Laura Gaitan. Camila's work impressed the judges with its creativity and depth. The more time we spent with her piece, the more meaning it reveals. It's a beautiful and thought-provoking piece of work. Camila says she loves the capybara because it's pretty and because it's part of my friendship with Ada and Vale, my best friends from high school. Our next artist is Mara Clausen. Her work is entitled Practicing with a View, using acrylic paint on wood. This was created during her art residency in Woodstock, New York. Mara painted from life to capture the beauty outside her window. Her work is a stunning example of direct observation and appreciation of nature. An excellent composition, beautiful, brilliant color, and magnificent use of material. Our next artist is Michael Baramoff. His work entitled My Favorite Things. Using the art form of a collage, Michael cleverly arranges his favorite things into the shape of his initials, making a powerful statement about gratitude and life. The judges all appreciated his creative use of this media and loved this work. Our next artist, Peter Sonnenschein, calls his work Life is a Full-Time Job. Using acrylic and a paint marker, he reflected on the daily tasks of FD-related limitations, using powerful symbolism like the large X over the eyes to represent vision loss. This is a moving reminder not to take anything for granted. He did a beautiful job teaching us so much with this piece of work. Our next artist, Ravid Mendelovich, entitled her work Wolf Dogs. Using photography, this brilliant, beautiful photograph represents Ravid's strength, empathy, and an unconditional love. This is definitely a powerful, moving piece. Our next artist, Rebecca Newman, entitled hers Eiffel Tower. Using photography, Rebecca's striking photo captures the magic of her Paris vacation, preserving a treasured memory in perfect timing and composition. A beautiful, beautiful emotional piece. Our next artist, Sam Landau, used his iPad to paint his view in France. Sam shares his favorite summer view from France through this stunning digital painting. The composition and color are superb, perfectly balancing detail and simplicity. Our next artist, Veronica Siegel, submitted a magnificent video of her mother and herself working out in the fitness center where she lives. She shows us strength and creativity in her art, both in expression and composition. A beautiful job from all the judges. Congratulations to all the artists. Everyone is truly a winner. However, we were tasked with selecting first, second, and third place. So after careful consideration, the results are as follows. Third place goes to Peter Sonnenschein. Life is a Full-Time Job. Unbelievable creativity. The second place goes to Justin Sachs. 2 pieces moving forward and a bright future. Both magnificent pieces of work. Justin is absolutely a magnificent artist. First place goes to Mara Clausen. Practicing with a View. All of us learn so much from this piece. As one looks at it again and again and again, we see something different each time. So congratulations to you all, and congratulations to the winners.
Hi, everyone. It's a true honor to be able to bring FD Day to a close by introducing the amazing Rick Guidotti, recipient of this year's FD Champion Award, presented to people who have gone above and beyond in lending their talents to help raise awareness and appreciation of the FD world. After a remarkable career as an award-winning photographer for the fashion industry with clients all over the world, Rick had a transformation in 1997 when he encountered a young woman living with albinism. As an artist, Rick was taken by her extraordinary beauty. To better understand albinism, Rick turned to medical textbook and was shocked by the dehumanizing images depicting genetic disease. As a result, Rick turned his lens on the beauty and richness of human diversity, founding his NGO, Positive Exposure. Since then, Rick has spent over 25 years collaborating internationally with advocacy organizations, medical schools, universities, and other educational institutions, using his photography to change attitudes towards people living with genetic, physical, behavioral, and intellectual difference. Over a decade ago, I approached Rick to ask if he would photograph the FD community. With his usual extraordinary enthusiasm, Rick agreed immediately. After a day-long photo shoot with many FD folks and their families, in 2014, we worked with Rick to create a groundbreaking exhibition with these photos at the NYU Langone Medical Center Gallery. Since then, Rick has done a number of photo shoots with the FD community. His wonderful photos grace the Foundation's website. In 2019, Rick created a short film on FD using voices and images of people from our community as part of a video for an initiative he calls FRAME, Faces Reframing the Art of Medical Education, and always including those who can speak for their own situation. In February 2024, we collaborated with Rick on a show of the riveting artwork of FD artist Peter Sonnenschein, some of which you just saw, hosting that at the Positive Exposure Gallery in New York City. We are so grateful for Rick's vision and vitality. It's my honor to introduce Rick Guidotti's response to receiving this year's FD Champion Award, and we'll hear a few words from him about that.
Hi, everybody. Thank you so much for this incredible honor, the FD Foundation Champion Award. It's such a thrill to receive this, but the real honor, you must know, the real honor has been working with all our FD families and our community at the FD Foundation to see the love, the importance of community, and to see the FD Foundation build that community and invite me in as a family, as part of that family, has been one of the greatest honors of my life. It's been such a thrill for me to be part of that, to document, to photograph, to listen to the stories, to create a film about familial dysautonomia, but really, so importantly, to see the community that's been built by the FD Foundations. So thank you so much for this great honor, and I'm just so excited, but I can't help myself because I have to wait 1 second. You all look just so gorgeous. I just can't help it. It's just, oh, look at you. Oh, amazing. Amazing. Wow, amazing. Thank you.
And Rick, for your well-deserved honor. We appreciate the wonderful work you do on behalf of our community. It's hard to believe we have come to the end of another FD Day. I hope each of you is encouraged to hear about all the wonderful work being done through the Foundation, at the Dysautonomia Center, and by the many brilliant scientists and researchers working on behalf of our community. Before we conclude, I want to acknowledge all of our speakers and everyone who worked so hard to put this program to put today's program together. I especially want to thank all of you for joining us for our 40th annual FD Day conference. I hope that you are heartened by the updates you heard today, and I encourage you to stay connected with the Foundation and with the FD community throughout the year. Remember, the Foundation is here for you. You will receive a post-FD Day survey shortly. We encourage you to complete and return the survey, as your feedback is important to us and will impact our planning for next year's program. In just a few moments, we will launch the FD Day After Party for people with FD, led by our facilitator, Michelle Schwab, and co-hosted by the FD Social Committee. You will find the Zoom link posted in the chat. Thank you all, and see you next year. Lehitraot.